Well, welcome everybody, and good morning, and to the third Health and Wellbeing Board of the municipal year. Before we start these proceedings, may I bring to your attentions to some of the housekeeping matters. There's no expected fire alarm today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house, which is basically leave at the front. And we're supposed to be in a council car park down there, but it's a little bit constricted, but never mind. So this meeting will be broadcast live and capable of subsequent repeated viewing. By entering the Warspite room and during the course of the meeting, committee members are consenting to being filmed and to use the use of the recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you are not using it, and your mobile device is turned to silent. Right, item 1, apologies. Elliot, do we have any apologies for absence?
Thank you, Chair. Apologies from Councillor Carlisle, Councillor Watkins substituting today, and apologies from David Haley, Director of Children's Services.
Welcome, Kathy. You're always welcome. Declarations of interest. Anybody, any declarations of interest? Nope. Lovely. We can move on then. Move on to item 3, Chair's urgent business. I've not been made aware of any urgent business. Right, the minutes are on page 1 to 12 of your pack. Are you content that they're a reasonable record? Those of you that can remember that far back to September. I propose that they can be accepted. Can I have a seconder, please? Thank you. Thank you very much, Tony. Questions from the public? Oh, sorry, can I have a second and then can I show everybody else agrees? We're all happy with them. Thank you. Excellent. Moving to item 5, which is questions by the public. Have there been any received, Elliot?
No questions today, Chair.
Thank you very much. Thank you. So we move on to a verbal update from the vaping working group. So I must have Dave Swartz somewhere online. Dave, the floor is yours.
Thank you, Chair. Yes, I've got an update, and so this is for the Health and Wellbeing Board in terms of a vaping working group and a progress that we've made. So at the Health and Wellbeing Board meeting on September the 14th, Dan Priest and I presented a paper that was an update to the 2019 Health and Wellbeing Board position paper on vaping. A key area of difference highlighted from the position paper in 2019 was the increase in vaping by children and young people. It was therefore recommended that a focus be made on this area to update the board's position in regard to its position paper, and this was agreed. An initial meeting with Councillor Aspinall, who's the chair for this process, it was agreed that we would run a workshop where we would invite a range of key stakeholders to contribute to the lines of inquiry which we'd agreed to look at. A report capturing the learning and recommendations for the updated position will be brought back to the board for consideration and approval. Linked to the focus on children and young people, through the work we begun to do, we also identified that a lot of this increase among young people seems to be also associated with a significant increase in the use of disposable vape devices. The disposable vape devices are also more likely to be linked to the illegal supply of unregulated devices. And also there's a concern in relation to disposable devices in relation to how they are actually disposed and environmental impact. That helped us to identify some overarching lines of inquiry, focusing on regulation, children and young people as a population, and the environment. We had an agenda and scoping meeting on January the 22nd, that's Monday, and these are some of the key areas that we captured at this point. In relation to regulation, we picked up on the regulations themselves and the controls that are available. There was also a range of emerging issues that we were picking up on For example, overstrength products, counterfeit e-cigarettes, and the child appealing marketing of that. We're also interested in relation to intelligence and insight and how that could be shared with our trading standards colleagues, and also examples of enforcement work that's been undertaken. With relation to children and young people as a population, we were looking at issues around prevalence and trend, understanding factors that influence use, vaping behaviours, and by that we're looking at the population using nicotine or flavour-based vapes, and also a much smaller population, but with a high significance for those that are vaping substances controlled under the Misuse of Drugs Act. Other key issues that we noted of importance was issues affecting schools, and we also were looking at evidence for vaping by under 18s and messaging that we could use in order to build our prevention and response approaches. In relation to the environment, we were considering the issue of how to safely dispose of the disposable vapes. There is a significant challenge because the battery is actually built into these devices. You can't separate the battery out from them. They're currently classified as and regulated as a WEEE, which is a waste electrical and electronic equipment. This means they're treated a bit like electrical toys and toasters. We can't put them in our bins outside our houses. You have to take them to the recycling centres. But as I said, it's not easy because the batteries are built in. Not you can't pull them apart. So there's a whole range of issues that are also linked to these disposable vapes. So we're now going to work through these, but as you can tell from the scope of what's come out there, there's a lot of things that are covered and linked to the use of children and young people. We also did identify that we've got a lot of work that's in place or being implemented, which is new, which we'd also like to capture going forward. So we are suggesting that we defer our report to the board probably until June in order to give us the appropriate amount of time to cover this. The other point of significance around that may be that government may, during that period, also report on some of the recommendations that fall out from their consultation around vaping with young people, and we'd obviously want to be in line with some of those. So we'd like to kind of defer till June. So that's the update.
Thank you very much, Dave. It was very noted that, of course, with the consultation that ended, I think it was end of November, December. That won't be coming out till sort of probably the end of January or February time. So it seemed rather foolish to carry on until we knew what those recommendations were. But I want to say a big thank you to Dave and to Dan Priest. They've done a lot of work about this, and certainly getting the trading standards, Alex from the trading standards was into that meeting was really excellent. So thank you to those that came along to that meeting. I think we got a lot out of it. So it is a case of watch this space, but as soon as the government produce their recommendations from it, and I'm hoping there's going to be some really tough ones that we can work with and utilise, we'll reconvene and we'll get a workshop organised, and as we say, we'll get a report back to you. And if there is anybody here that wants to join that workshop, you're very, very welcome. We need to make sure there's a wide range of people there, so hopefully we can move forward. Thank you very much, Dave, for that. I'm impressed you kept to the timing. Wow, thank you. We'll move on now to item 7, which is the Health Watch patient. I suppose I should say, sorry, we need to ask you to note the update, and if you've got any suggestions, please let us know so that we can incorporate that. So we move on to 7, which is the Health Watch Patient Experience of Pharmacy Services Report. And this is very timely because obviously the item after that, we're looking at our pharmacy and pharmaceutical needs assessment. So Tony, thank you. As usual, a fantastic report, very detailed and very informative. So please thank the team that put it together for us, or for everybody from us. All right, thank you. So the floor is yours.
Thank you, Chair. I've got a presentation really just to pick out some of the highlights from the report. Otherwise, we might be here over time. I think what we'll do is just really concentrate on why we did our report. So I think there was a couple of things that happened last year. Firstly, the announcement of closures, the in-store pharmacies at Sainsbury's across the country, and then Boots making an announcement that they were going to review their stores and that because of financial constraints. And equally at the same time, Healthwatch England started to review patient experience across the network of pharmacy. We'd previously published a report in May 2022, so it was a good chance for us to actually review over 18 months whether things had improved or remained the same. And I think generally what we picked up in the review of our patient experience was that access to service, waiting times and medication delays were still the evident themes that were coming from patient experience. So what did we do? I guess we started conversations in July last year about our concerns and worked with the local pharmaceutical committee and NHS Devon Primary Care Committee to raise those concerns. And I think the biggest one for us was if we had these closures and the impact of staffing on existing pharmacies, what did that mean for the community pharmacy first initiative that's just about to come into force. And as such, we shared that intelligence with those partners and have had some really useful conversations. I think the conversation with the local pharmaceutical committee was really useful because it gave some context to some of those issues. Rather than, us just thinking, it's a real patient struggle. And there are struggles out there, but the context why those struggles are there was really useful to understand. So what did we find then? I guess the majority of the experiences we looked at, and this is people just contacting us, so we didn't go out and do any actual engagement as such. 77% were negative, and the majority of the experiences we received related to pharmacy services in Plymouth predominantly, and in particular there was a proportion of that related to the Lloyd's pharmacy at the outpatient department at Derriford Hospital. I think the graph quite handily sums that up where that experience has come from. So the themes, again, medication, issues with supply, incomplete prescriptions and waiting times around medication being available, staffing experience around staffing levels, their capacity, and sometimes the quality of the service that was being provided. Administration is really about systems and protocols and does include how scripts are done, whether that's done electronically through the either online or NHS app, or you're dropping the scripts into the surgery or to the pharmacy. And access to services. There was, I think, early last year, a period where certainly the chain pharmacies were having to review their staffing because of shortages, particularly of pharmacists and pharmacist assistants, which led to some temporary closures at some of those pharmacies. And I think some of that has now turned into permanent closures. One thing I would say is, from information we've received via the NHS, is that with Boots, where there has been closures, there's been a redeployment of staff, and actually opening hours have been extended in those services that are remaining open. So I think, you know, there has been a look by providers of those services about how they can continue to provide a service, albeit in a lesser extent from a locality point of view. The next slide really just highlights some of the actual feedback we received. I think it really talks to itself, and it's just a snapshot of what was in the report, so I don't propose to go through there, but it really, I think, gives an understanding of the patient experience. So we made some recommendations to stakeholders within this, and which are there. We asked NHS Devon to provide a response to the experiences and provide details as to how the issues raised in this report will be addressed. So there is a pharmacy strategy consultation group being set up in NHS Devon to look at pharmacy moving forward, and that has key stakeholder involvement, and I'm sure David will add a bit more to that. This is to, as you're aware, pharmacy is part of NHS Devon's remit for commissioning now under a what's known as the POD, which is Pharmacy, Optical, Dental Services Delivery. So therefore, it's right that they look at a strategy of how that's going to happen in Devon, given its vast challenges either in the urban or the rural setting. We've recommended that an answer phone facility is in place at pharmacies, so that if they don't have capacity to answer the phone at the time somebody rings, when they have capacity, they pick up the messages around that. And the final one is NHS Devon considers our findings and provide a response. And on that note, I think we've had some good response, not only from NHS Devon, but from the LPC and also from UHP as well, when we looked at the specific issues around Lloyd's Pharmacy. And I'm happy to say the final recommendation on this one is we do have links in with UHP. We've been up for an on-site visit to look at the new pharmacy. Yes, there are issues now at the moment for people with mobility in particular, but I guess it's the devil in the deep blue sea in some respects. You know, with the recent period of wet and very cold weather, waiting outside or waiting inside at that stage is a question, you know, that needs to be resolved, and it's how you get around the mobility issue. And I think they've got some plans there to look at that, including using their little on-site bus service. I'm not going to read out the responses. They were in full in the report, but we've just pressed them here on this slide. And then finally, the response from University Hospitals, Plymouth. I would say the chief pharmacist up there is very pragmatic, but he's also got a drive to improve the situation. And they have looked at several measures, some of which is outside of their control. And another one they did look at was bringing the outpatient pharmacy back in-house rather than it being contracted, because they're an NHS trust, they're not allowed to do that. So there's some governance legislation issues that they also have to contend with up there. So the next steps, we're here today, obviously presenting here, but the plan is to present at the two other health and wellbeing boards. Continue to work with NHS Devon and in particular the LPC, and we've recently attended an LPC committee meeting to discuss the role of Health Watch, but also to touch on the report as well. And we will continue monitoring patient feedback. I would say from a Plymouth perspective over the Christmas period, probably about 80% of the feedback we received was around pharmacy. And I'm happy to take any questions.
Thank you, Tony. That, as usual, a brilliant report, and very much, I think pharmacies are becoming one of those hot topics really in Plymouth, aren't they? Which is very unfortunate. In regards to the hospital one, I think certainly it is from Plymouth Area Disability Action Network's point of view, they are very concerned because of that steep incline to where they're going, and of course there's limited parking. So I think that's something that Derriford need to take up, is you're not supposed to be parking on that little bit where the pharmacy is going to be. But having said that, there's going to be quite a few people whose relatives will have to go up there or whatever. So, and I think the reliability of the bus, the bus, I mean, it's a brilliant service, but it's not always constant because it's actually run by volunteers, and we all know volunteers can get ill. So I think that's a conversation that we really need to have with Derriford as to how we do that. But I suppose there's several of us will have been queuing outside of that door in the rain and whatever, and before they brought the chairs there, that appreciate the fact that the other service will be much better. But I think we just need to get the logistics sorted out. In regards to the closures of Boots, I mean, we're being made more and more aware of other surgeries, aren't we? Other pharmacies now that are restricting their hours or whatever. And certainly from the Boots point of view, I mean, I've got to be honest and say I go to the one on Salisbury Road, and that's one of those that are closed. And of course, they're not getting the supplies back. So the other day she was saying she ran out of some antibiotics. So I think that's also going to be a problem with these phased closures, that people are going to find more problems with getting them. But I think I can understand their logic, but it's not thinking of the community really, and the needs of the community. I think that's what really concerns me. Right, any other questions, John?
Thank you, Tony. Very comprehensive report, and it doesn't surprise me at all from personal experience, what I hear from friends about can't get through on the phone, queuing, haven't got stuff, it comes in bits and pieces. And as for Derriford, I think we need to remember that if I'm correct, the Lloyd's pharmacy took over the outpatient prescribing because, you know, there were such long queues when it was being managed in-house by the hospital pharmacy. I suppose if they have a different site, then if they could run it themselves, they might be able to solve that problem. But in my day, I don't know, consultants were able to write prescriptions that could be taken to a community pharmacy, not necessarily to the one at Derriford, and I don't know whether that's the case. And for certain people who have mobility problems, who can't wait for an hour at the pharmacy at Derriford, a prescription they can take to any pharmacy surely is one of the ways forward, and a lot of people might opt to do that. But I think pharmacies have a problem because they haven't got much space. I'm convinced now they're under-resourced, probably unlike the rest or some of the rest of primary care. Pharmacists are being pinched by GPs who are getting, extra funding to do that, and they are, and they haven't got the space in their small, shops, most of them. And when we're saying to patients, well, don't trouble your GP, well, I think that's probably who we should be troubling. Go to the pharmacy. Are people actually doing that when they've got a queue outside? And I just can't see how that's working. So my question really is. Is general practice creaming off a lot of the resources in pharmacists in terms of manpower regarding pharmacists, and also other palatial premises that really, actually, if we're going to make pharmacy, you know, the place where people go as a first stop, then we need to put a lot more money into it. And I don't think that's happened, and I don't think it's going to happen. That's my question.
I think with that question, Councillor Mahoney, that there's other people in the room better qualified to answer that one. But what I would say about Derriford is that in discussions with the chief pharmacist, they are trying to, if you like, where they can, prescribe so that it can be collected at your local pharmacy, or you can take an electronic or take a script away to go to your pharmacy. I think the issue is that a lot of the medication they actually prescribe at some of those outpatient clinics is specialist medication, and therefore there's very, you know, if you took the script to your pharmacy, it's not going to be there anyway. So yeah, there's some challenges there, but I think they understand the challenges, and they're looking at how they can get over those, or provide, at least where they can, a service that allows somebody to leave the hospital with a prescription.
Thank you. David, do you want to come in there?
Yeah, I think that the reality is that undoubtedly the funding has been a significant issue. We've had flat cash for 5 years, and in an inflationary environment, that's very, very problematic. And you do get to a point where a lot of those areas are unsustainable in terms of their financial viability, which is why you're seeing what you're seeing at the moment in terms of access reductions, in terms of hours of opening and closures. The government are aware of this. There's been significant conversations going on about the level of funding, and we have got the Pharmacy First service, which is the first injection of cash we've had in that 5-year period. It won't be enough to resolve the issues that we're talking about, but it is a positive step, and one we embrace as a community pharmacy area, because it gives us opportunity to grow into the future and offer a greater level of provision to the public. So we really welcome those new services. You asked about supply, Mary. I think there is a fundamental issue of supply. It's one, again, that isn't in the funding envelope to deal with the level of issues that we've got. When we 5 years ago, there was nowhere near the supply issues we've currently got, and it takes a huge amount of time to try and resolve. And it's part of that burden that we're actually coping with in pharmacies at the moment, and the supply issues are not going away. It's a growing issue, actually, and it's partly to do with we have very tight controls of cost in the UK compared to others, so there is, I guess, to some extent, the market forces driving where those goods go to. So I just want to emphasise that these issues that you portray are not in any way the result of unwillingness from pharmacy teams. They are working their utmost to do what they can for patients, but there is a significant pressures in the system. And there are also some really, really good positive stories about joint working and where pharmacies are providing significant hypertension services, etc. So, you know, there are some real positive examples of actual pharmacy can offer huge things to the community where those integrated relationships work properly. I think, John, to your question, there are issues of workforce, absolutely, and clearly the workforce expanded into other areas, including practices, etc., and that does exacerbate the pressures that you see within the workforce arena. We have got plans. I think the opening of the School of Pharmacy in Plymouth is a huge benefit, but you know, it's reasonable to say it's going to take a few years for us to actually address those workforce issues. We are doing what we can, though, in terms of initiatives around marketing, etc., to draw people into our area. But yeah, we do have a shortage of pharmacists, and importantly as well, probably an increasing shortage of technicians, who we will use more and more as their ability to actually intervene into clinical interventions grows. We want to use more and more technicians, and again, we have a shortage in those areas. Space is an issue, because actually, as you do more and more items through a particular location, the storage of those completed things are an issue. But we have coped with that to some extent by hub and spoke and by direct to shelf and things such as that. But you're right, in in some instances, in some locations, space will be a problem as you reduce the number of pharmacy outlets you have, and you condense them into less locations. So it is an issue, but we are doing some interventions that to some extent help that. But I'm not going to decry that yeah, in some instances where you do closures, you're going to potentially have a capacity issue.
And certainly I'm sure Boots will be absorbing their staff into their other branches, so that would be reassuring that some of those will at least have a few more people in their staffing. Jemima, you've got something to...
Thank you. Well, David's sort of answered one of my questions, which was around the government's place in all this. I think we're on about our 5th pharmacy minister since 2022. And so that concerns me insofar as the message might get lost along the way, actually, how bad it's become, because I've had emails from residents who are panicking because they're, one of their daily prescriptions that they've taken for a long time, they're worried about the supply of it, which is an awful thing to have to worry about. And it's not unusual to drive past a pharmacy and see a queue of people outside. And these are kind of new things. And I think I just don't quite understand what's at the nub of it. What, why is this happening to all these pharmacies now? In your very good report, Tony, there was, I sort of laughed when I first read it, but reflecting now, there was somebody talking about using horse ointment to treat an eye infection initially, before she had to go, thought, well, I'll have to go to the pharmacist because it didn't work. Well, we can't have people using animal medicines because, they're worried about getting a GP appointment and then worrying about whether they're going to be able to get, have the time to queue to see a pharmacist. And also I don't see, again, how it tallies up with the message about, as Councillor Mahoney was saying, go and see a pharmacist to save, GP time and all the rest of it. Those two messages just don't marry up. So I think I'm just trying to understand what, if you're able to describe what's causing this. I don't know how long. I'm trying to think how long it's kind of been an issue with residents, and I've seen it, and I guess there's a pandemic element to it as well. There must be. But yeah, I just want to try and understand what's causing this. And then my second question is about the government in terms of those discussions that you said have been positive. What, in terms of funding, you said it hasn't changed for 5 years. What's coming out of those discussions, and do you feel there is an understanding actually how problematic this is becoming, certainly for Plymouth?
David, do you want to take those?
It is something that's been slowly growing in terms of it. I think it isn't just the nature of funding. The patient demand has grown too, and probably expectations have grown. And reality is there's only a fixed resource because we've had flat cash. So at some point, obviously, demand and capacity become imbalanced, and there's an element of that going on. In terms of particular case of Plymouth, and the Southwest has been more affected by closures than the national average, and that's partly because of the workforce issues. We have higher costs here in terms of workforce because of the shortages. So locum rates, etc. We run off locums more than the average, and obviously that has a cost implication. We also have some unintended things going on, such as when they do clawbacks, we have something called a global sum, which is basically for the amount of margin you make on your purchases. But they do a reconciliation every few months, and they claw back any over recovery or we make. And
sorry, when you say they, who are you talking about?
Government. And in our case, there's one particular product this time that was a massive over recovery on. So they claw that back on a national average, but we don't use that product here. So basically, our local pharmacies have been very much hit by that in terms of finances again. So there are some of these mechanics that go on that can have unintended consequences, and we are definitely probably more financially stretched in the Southwest than the average across the piece, which probably doesn't help, and that is probably why you're seeing a higher level of closures here. There are other mechanics going on as well, such as rents for pharmacies in GP surgeries are high, and that's why you're seeing a higher number of those potentially going and people moving out of those. So the rents actually are one of the drivers of some of this as well, because the economics are obviously critical. So there are really a multitude of factors going on here. It isn't one driver. There is a multitude of factors that are driving this happening at this particular point in time.
I'll just come back there. So it's interesting because obviously one of the things that I'm particularly interested in campaigning a bit around is dentistry, and it's that clawback word, which often seems to be, if not at the heart, but kind of quite central to ongoing, financial issues. I'm interested in the rent thing as well. Then I don't know, Chair, whether there's anything we can think about recommendation-wise. I don't know. I mean, I guess it's a plethora of landlords, I assume. Is it? Who tends to rent those buildings to those pharmacies?
There's a multitude. Obviously, in the case of a GP practice, it will be the GP practice subletting that space. But in a lot of instances, you're on the high street. They may actually be owned, which will be a better situation for them. But there is a multitude of different people that own those properties.
Yeah, I don't know. It'd be complicated to do a recommendation around that then. But I mean, if that's a really big driver, that's something we could look at in some way.
And I think it links into the next item as well. I think I wouldn't be expecting Housewatch to be doing stuff about the rents, etc. But I think it does. No, it's not an apology. I think it's something to note, and then it links in very well to the next one. Kathy.
My concern is with suggesting people should see a pharmacist rather than a GP is that pharmacists aren't actually qualified to do diagnostic work. And in my experience, when I've actually seen a pharmacist instead of a GP, I've been sold a product which I may not need, or I may have just needed advice, or in one case could have actually caused me harm. And I had to see a GP afterwards anyway. So in fact, it was time consuming for me, time consuming for the pharmacist, and I might as well have just gone to see the GP in the first place.
Can we hold that for the next item? I think that's much more there. I think if we can just dwell on the report at the moment and keep to that. I think none of us will be surprised by the content of this report. Tony, you contact 121 people contacted you. Is there any way that you would benefit by Plymouth City Council if you were doing some consultation, putting that on our website so that at least it's there and on it? So, I mean, that presumably, Gary, is something that we could do to help, isn't it? There's that contact rate.
I thought the report was really good, Tony, and we can always make those links and references to those other things to help facilitate more information and feedback, really, to kind of add strength to the report.
I think the quality of your reports that come out, regardless of what the subject is so important to Plymothians that I think we need to make sure that link happens and that Gary and the team know when something's cropping up so that we can help you in that. I think that would be one of my recommendations from today. And then I think, do you mind if we hold and put, when we talk in a minute about the pharmaceutical needs assessment, I think what you've discussed and Kathy's discussed needs to be added into that, because I think that's vital. Tony, can I ask you to thank the team, as I say, for the brilliant work they do, that your reports are so clear, so easy to understand, and some of the stories are always heart-tugging, definitely, when people have had real big problems, but we need to hear them and we need to be talking. I mean, one of the things that I will do is discuss whether it's with David or with Chris, I'd like to meet up with the chief pharmacist at Derriford and have a conversation with him about the new building. I don't decry that they need a new building. I think we just need to make sure that we've got the fine tuning there for accessibility, regardless of whether you're disabled or whether you're older or even younger. You know, you can't do that. So let's have that conversation, please. Thank you very much indeed, Tony.
Thank you, Chair.
That leads us very nicely into the pharmacy and pharmaceutical needs assessment update. What we do this every few, I think it's 3 years, and we had done a pharmaceutical needs assessment recently. However, as we've just discussed, a lot of things have changed. So I really felt very strongly that that needed to come back to us so that we can have a look at it. One Devon is also looking at it from various things. And one of those things we need to do is, do we work with other councils, or do we punch our weight and do it a Plymouth thing rather than joining up with other people? So that's what I need to steer from everybody. So I'll hand over, presumably Rob, you're leading on this?
Yes, well, morning everyone. So keeping going with the theme of pharmacy, myself and Dave are going to do a double act on the sort of pharmaceutical needs assessment and then some challenges and options going forward. So just by way of introduction, for those people who don't know me, I'm Rob Nelder. I work in the City Council's public health team, and I'll introduce Dave. Dave, I think you all know Dave Bierman, Director of Strategy of what is now called Community Pharmacy Devon, formerly the LPC. So the LPC is now Community Pharmacy Devon. Right, what do I point this one at, Elliot? Am I pointing it at you, or am I just generally pointing it to move on? There you go, look at that. So this is what we're going to cover briefly. What is a pharmaceutical needs assessment, or PNA, and what are the Health and Wellbeing Board's responsibilities in that regard, because you do have responsibilities. Then we'll quickly go through the list of which pharmacies have closed or are planning to close. And I'm just going to mention these things called supplementary statements to the PNA. We're going to talk about our proposal to go early with the next iteration of the Plymouth PNA. Then Dave's going to take over and talk about the current situation, some of which we've heard already, the opportunities that presents. It's not all challenges, there are some opportunities as well. We'll mention the NHS Devon pharmacy strategy, the links to the PNA, and the opportunities for yourselves to get involved in that. And then there are a couple of recommendations at the end that we've suggested, basically. So, okay, there we go. So, starting off with what is a PNA and what are the Health and Wellbeing Board's responsibilities. It's outlined on the slide there, just to pull out a few key points of what it's supposed to be. So it's this thing about a PNA being a comprehensive assessment of current and future pharmaceutical needs of the local population. So that's what it is in a nutshell. And why are we talking about it here at the Health and Wellbeing Board? Well, it's because the Health and Social Care Act transferred the responsibility to develop and update PNAs from primary care trust to health and wellbeing boards from the 1st of April 2013. So this means that we, or you as a health and wellbeing board, has a legal duty to ensure the production of a PNA for Plymouth. So it's really important that we do this, and it's really important that we get it right. So we had to produce the first one by the 1st of April 2015 and then publish a revised assessment within 3 years of that. And so there's that 3-year cycle. We got slightly out of kilter with that 3-year cycle during the pandemic, the height of the pandemic, when the lifetime of the PNA was extended, if you like, because there wasn't the capacity within public health teams to update them. And it is normally the public health team within a local authority that produces the PNA on your behalf. But I'm not going to let you off the hook there. It is your responsibility. Sort of the public health team are doing it for you and with you, if you like. So we last published our PNA in September 2022. And that was for the period, or should be for the period to take us up to September 2025. So we've got a live PNA at the moment, published in September 2022 to take us up to September 2025. So as I said, the P&A for Plymouth presents a picture of community pharmacy need and provision in Plymouth. So the key thing is that if a pharmacy or a dispensing appliance contractor wants to provide pharmaceutical services in Plymouth, they've got to apply to NHS Devon to be included in the pharmaceutical list. And this is the key bit. Their application must offer to meet a need that is set out in the Health and Wellbeing Board's P&A, or to secure improvements or better access similarly identified in the P&A. So in effect, in their application, they've got to address something that is outlined in the P&A, normally a gap of some sort. So as well as identifying if there is a need for additional premises in the P&A, it also identifies whether there are needs for additional services or services, whether so it's additional premises and additional services. Those are the things that the P&A identifies. And those identified needs in the P&A could relate to better access, which could be current or will arise within the lifetime of the P&A. So what I mean by that is, I'll give you an example. If there was a massive housing estate that was being built in or around Plymouth, then that might change the need for pharmacy services in the lifetime of the P&A. So we have to consider those things as well that might happen during the lifetime of the P&A. So, in summary, the P&A is used by NHS Devon to inform decisions regarding which services need to be provided by community pharmacies, whether new pharmacies or services are needed, decisions about the relocation of existing pharmacies, and the commissioning of locally enhanced services. So those are the key things that the P&A will be used by NHS Devon to decide. And obviously providers, as I've said already, providers of pharmaceutical services will use the P&A to inform their applications to provide pharmaceutical services by showing they are identifying a need or a gap. So that's the key thing in the P&A very often, is this thing called a gap analysis, which shows where there are gaps in the city that providers of pharmacy services might want to fill. So moving back, there we go, we've moved on two, we're now back one to where we should be. So the list of pharmacies which have closed or are planning to close, there are 7 on this list. Lloyd's and then Boots. The other thing that isn't on this list, just to make you aware of, there's an application by Superdrug at the moment to consolidate their 2 sites in the city centre into one location. So that's the thing that isn't on here, because that's in the application stage at the moment. So Superdrug in the city centre have got what's known as a consolidation application, I believe that's the term, as they want to consolidate their 2 sites onto one. But as I say, this is in the pack anyway, and I'm sure you're aware of which pharmacies have closed or are planning to close. The other thing that we do, so we publish the P&A, the Pharmaceutical Needs Assessment. You may have seen it. It's published on the Plymouth City Council website. And what we can do is we can issue these things called supplementary statements to the P&A when things change. So supplementary statements are statements of fact. They don't make statements about the need for pharmaceutical services or revised need for pharmaceutical services. They're simply statements of fact. So we are going to be issuing, and I'll show you what a supplementary statement looks like. There you go. There's one in the presentation. It's literally makes reference to the date the P&A was published, the date of issue of the supplementary statement. You can ignore that. It says 8th of January. Obviously, we've just drafted these supplementary statements. We won't publish them until after this meeting today. So that will change. It just talks about what has actually happened in terms of the facility, what's happened. In this case, it will be closures. They'll talk about and it gives some reference to the provider. So after the meeting today, we will have to issue, I believe, 7 supplementary well, not 7 because they're not all closed yet. We issue them when the pharmacies close. Those supplementary statements will be added to the P&A. But that's what we need to do. So as I say, we can't issue, when we issue these supplementary statements, they don't say whether a gap or not has been created. They literally say that a pharmacy has closed and the services it used to provide. But as you will see from what's included in the presentation, 7 pharmacies have closed. And so myself and Dave next to me and colleagues from NHS Devon have had conversations about whether that is sufficient to enable us or to require us to revise our pharmaceutical needs assessment in its entirety. Pharmaceutical needs assessment, as I've said, needs to be produced every 3 years or within that 3-year window if there's been significant change to the pharmacy situation in an area. We think that the closure of 7 pharmacies and the consolidation application means there probably has been sufficient change to pharmacy delivery in Plymouth to warrant us producing an updated PNA. So that's why we've included this section on the reasons for this proposal to go early. Those changes are of a significant extent, we believe. So what we'd like to do as one of the recommendations later on is for you to consider our proposal to go early and produce an updated PNA. It's not massively, we're not going massively early. We're not due to produce another one until September 2025. These things take 9 to 12 months to produce, because one of the things you have to do is a 60-day consultation. So that eats into a significant amount, or takes a significant amount of time. So what we're looking to do is to produce the next PNA by March 2025. In effect, start producing it now, so that we've got something ready in March 2025. We would do what we normally do, hopefully, and that's produce something in partnership with the other public health teams in Devon. So our colleagues in Devon and Torbay, what we normally do is share the pain, I suppose, is the way to put it, in the production of the PNA. We produce certain bits, they produce certain bits. We all have a document that's formatted in the same way, and it works really well for NHS Devon because they haven't got to look at 3 completely differing PNAs. So what we'd like to do, as I say, is for you to consider at the end of this whether we're able to produce, whether you're happy for us to go early with the production of the PNA for the reasons I've outlined, the significant change that we are seeing in the city, and the significant challenges that Tony has outlined in the Health Watch report. What I just would say is, I've talked about us producing the PNA jointly with Devon and Torbay. It's just worth saying, going back to the point that Mary made, in terms of the Devon pharmacy strategy that's being produced, that's a separate thing. Okay, that pharmacy strategy that's being produced, we will use that to inform the PNA when it's published. So I think what Mary was suggesting is that we need a separate session with NHS Devon to consider our input into that pharmacy strategy. And then what we would do is we would use that pharmacy strategy to inform Plymouth's PNA, but we would produce our PNA in partnership with colleagues in Devon and with colleagues in Torbay, as we have done for the last however many years I've been involved in this, lots of years basically. So that's where I've brought us up to. I think we're going to move on now, and Dave's going to talk about some of the current, update people on the current situation, to go into a bit more detail on some of the things we've talked about already. So shall I hand the clicker over to you, Dave? Just the right-hand button there.
Yeah, and just to reinforce what Rob said, really, I think the Health and Wellbeing Board is quite a different situation for pharmacy than the others. You have more responsibility for pharmacy in any other part of the health system, and actually you basically hold one of the primary mechanisms for the delivery of the pharmacy strategy in your hands. So it is really quite important that you get involved with pharmacy above and all other healthcare situations, really. So I just wanted to go through the current situation. Oh, blimey, it's sensitive, isn't it? As we've already talked about, the sector's under unprecedented challenge. Financial challenges we talked about, workforce issues we've already talked about, supply we've already talked about, and there's operational things and workload as well, in terms of increased levels of activity that are leading to this reduction in access we talked about. We have seen significant closures in Plymouth. It is one of the highest closure rates in the country. it could be up to 20%, well, nearing 20, I won't quite reach 20% by the spring. I'm not saying there will be more closures, but I don't, from the conversations we've been having with the national team, we don't believe the closure stream has finished. So there is an anticipation there will be further closures at a national level. Whether they will impact on Plymouth, that's difficult to ascertain at this point. In May, the Department of Health and Social Care and HSE published the delivery plan around recognising the need to recover access to primary care. And that actually included that the pharmacy first service as one of the solutions to the access to the primary care agenda. So it's quite clear within the strategic thinking that pharmacy is going to grow in importance in terms of service delivery and that first point of contact. So it's really, really important we have a robust infrastructure to deliver that, because that's clearly a national intent that pharmacy will take off a significant chunk of the demand coming into the primary care sector. So that's a real reason when you think about the robustness of the pharmacy sector. In terms of our opportunities, we probably aren't maximising some of our existing services, actually. So things like the new medicine service, which helps support people when they move to a new medicine, the discharge medicine service, which is looking at how you manage discharges from hospital and reconciliation of medicines, which is known to have actually a real impact on readmissions and actually length of stay in hospital. So some of those things we know that can have an impact on system demand, we probably could do more to maximise. The new services coming out is basically a growth of the existing ones we have, which are the CPCS and the GPCPS services, which are urgent care services where they're largely referral from 111 and GP. But the new service is going to also include walk-in capability, which is a real positive move. Alongside that, there's things like emergency repeat medicines, etc. But the new thing particularly is around the clinical pathway consultations, which will occur around sinusitis, sore throat, acute otitis media, infected insect bites, impetigo and shingles, so, and uncomplicated UTI. So the scope is significantly increasing, and it will be driven out of a whole number of PGDs, which have been printed out and literally that thick in terms of the level of governance that is going over the top of this. So there is potentially significant scope there to impact on the urgent care demand coming into the system. In addition to that, there's a new contraceptive service coming in where pharmacists are able to initiate oral contraception as well as manage contraceptive supply, which is already in place. So again, that's a real positive move forward in terms of what pharmacy can do and support the wider primary care sector. There's also an opportunity around independent prescribing. It's worth mentioning, you're probably aware, but community pharmacists will, as they come out from college now, all pharmacists will become independent prescribers from 25-26 in terms of that cohort. So, you know, that training around, it has become more and more clinical as we've gone through the last 10, 15 years. And that training will involve rotations into practices and acute care, etc., to get that independent prescribing experience. But as they go through college now, years 3, 4, and actually in the pre-registration year, you'll see that build up of clinical experience around ability to prescribe. So it's embedded in now the undergraduate program that learning and capability around clinical skills is far more in depth than it historically has been. So there's real opportunity here about what we then do with those prescribers that sit particularly across the whole of the pharmacy estate. And that will be over and above what I've mentioned there about the pharmacy first interventions. So you potentially can have a real significant level of support around things such as long-term condition management and broadening that urgent care intervention agenda. So potentially significant scope to actually enhance what we can deliver. Also, we have a hypertension service that's being expanded in terms of the number of ABPMs, and actually is one of the areas where technicians will become involved. So that won't be a pharmacist-only service in future. That's obviously one of the key preventative interventions we can make, and expanding the capacity of that will potentially have significant positive benefits for the health system. I've mentioned pharmacy technician scope, that was one example above, but the intent is to grow pharmacy technicians in their capability of intervening around vaccinations, all kinds of things. So the intention is to grow their skill base and actually have them involved in more and more of the service interventions. Medicine supply is being centralised, so we're looking to do that in order to enhance efficiency and capacity. And that's part of what I was saying, John, about the ability to actually create space. So the way we're creating space is actually automating things that allow us to actually reduce stock space, etc., so to create more space for other things within the pharmacy sector. Greater system linkages are occurring, but there's real opportunity to do more around that, linking up potentially with GP practice systems, etc., to improve safety. And you know, I think there's real scope here to improve care and improve safety and improve transfers of care between pharmacies and practices by actually improving that the system linkages. And utilising pharmacies in the prevention role. We obviously have healthy living pharmacies. There is a preventative agenda that we can deliver through pharmacies. There's a real opportunity to use pharmacy to support inequality. And also, NHS Devon and the ICBs, we're looking at potentially about setting up a small team to look at community pharmacy resilience and think about how we might exploit the opportunities. So, real opportunity there. So, what basically saying here is I appreciate what we've talked about in terms of the demand capacity issues, but there's huge scope if we can get that right to actually have a really strong support to the health sector by utilising the pharmacy system. In terms of pharmacy strategy, that's being developed at the moment, NHS primary care, to link into the NHS primary care strategy. It's going to be built on local examples of integrated working, but also there's a significant body of work, which I haven't bored you with, but there's many documents now around visions of pharmacy, etc. The key and most recent one is the King's Fund and Nuffield Trust vision that's come out. That will be utilised in actually thinking about what we do and how we take community pharmacy forward. But part of that, there's a significant level of engagement going on with health and wellbeing boards and with others, and actually there's a significant scope around that about engaging with a whole wide range of potential interested parties. And from that, we're going to take people through the national context of what community pharmacies are operating and practicing in, outline the number of community pharmacies in Devon and the changes that are occurring, highlight the challenges, and look at some of the good news stories as well. And that's the context of those engagement sessions. And it will be developed using those sessions, and the intent is to actually involve health and wellbeing boards in one of those, and look at, you know, the stakeholders and things such as, you know, what's happening around pharmacy service provision, what the opportunity is, and what can we do around those community pharmacy services. So it's a real opportunity for health and wellbeing boards to get involved in actually driving and developing the strategy. And the intent is to have that completed by May. Just wanted to flag, though, that it's really important in getting engaged in that, because we want to utilise the PNA to enable the delivery of that vision for pharmacy, working in partnership with NHS Devon. So what we're doing around the PNA and what's happening around the pharmacy strategy are very much linked, and it would be really helpful to actually start bringing the bodies together with NHS Devon around this, to make sure that we've got something that's integrated, coherent, and we understand our roles in actually delivering that strategy going forward. I think that's me.
I think that's the end. I mean, I guess there'll be a little bit of discussion, but those were the recommendations at the end that we've suggested.
Lovely, thank you. I'm going to bring in Michelle first and then John.
Thank you, and thank you for the presentation. I always find things like this quite inspiring, and you just see what the future can look like. But we've also seen that the issue that Plymouth has, and pharmacy is a strange thing around ownership and drive, isn't it? So, I just, even if I think back to basics around any workforce strategy, what part of the strategy is really looking at that from a national point of view? It's great that we're training in Plymouth, but have we done any work on how many people are likely to come up to retirement? How many pharmacists we actually need? Do we know the amount of support that newly qualified pharmacists will need in order to start to take up all of these exciting things? And again, the focus on technicians, how are we training technicians and how are we supporting them as part of their new role? And it just feels like I sit on the periphery of this as well, and it feels like we need something for Plymouth to really, really focus on the Plymouth issue and know what we need, as well as listening to what's happening nationally, because I think something special needs to happen here.
Yeah, thanks, Charles. Yes, we are looking at workforce. We've done some work with Simon Fuller around optioneering, etc., looking at the future out to 2035. We recognise that from start point we've got a gap, but we've been looking at what we need to do to plug that gap, looking at what level of international recruitment we might want, looking at what we can do around particularly accessing pre-registration, or what are now called IETP students. We think there's a real opportunity around that, because the way that it's now going to operate is going to become far more like medics. Everyone will have to go through a system called Oriel. They will be what's the word? They will be numbered, etc., in order to get a ranking, and they will then go out according to their preferences, just as they are with medics. Now, the reality is we know the number of places potentially going to come on offer, because of the way the funding's working, is going to reduce. Historically, we've only got something like 20% of the fill rate in our area. Actually, it's lower than that amongst community pharmacies. So we know that our fill rate will probably increase as a consequence. So there's real opportunity around that. And then there's also an opportunity because we're going to have the new School of Pharmacy down here. So we think we can get our numbers of what is historically called pre-registration students up. The question then will be is about what retention mechanisms do we put in place to keep them. So there are things around that. We've had discussions with Mary around this and around international students as well, and what that might mean. Regarding PTPT, which is the technician training program, it's a 2-year apprenticeship. That rotates around a couple of sectors normally. In fact, a lot of pharmacy education now is not organisation specific, it's increasingly system orientated. So you will see all pharmacists going forward after 25, 26 will have to rotate through more than one sector in terms of their final qualifications. And increasingly we're seeing that with technicians as well, which is a really positive thing. So it means we're training people for the system and able to work across the system going forward. So we have looked at real planning around this, it's not straightforward, and there's a lot of work to do, but we have plans in place, we think, to actually start addressing that. There are pinch points, particularly in general practice, around the huge burden we're expecting on them in terms of the training requirement, particularly around placements. But we are looking at that at the moment to see how we can increase that capacity. It's not straightforward, it's not easy, but we do have a plan, but we recognise there are significant challenges in delivering that plan.
Thank you very much, John.
Thank you, Dave and Rob, for your presentations. 2 questions, really, one for Rob and one for Dave. For Rob first, with all these pharmacies closing, obviously there could be a geographical problem for patients who find it difficult to access a pharmacy, but also, I mean, particularly with the Sainsbury's closing, and I recently had a text from Polar Pharmacy saying that they're going to be closing on Sundays, I think, as from the 1st of March. So what is the out of hours provision, the evening provision, the extended hours, let alone Saturdays and Sundays? What is the position there? Because it strikes me there could be a problem. And for Dave, I mean, yes, all this is admirable, but again, I don't see how it's deliverable in a smaller number of surgeries, pharmacies, with what appears to be a decreasing number of pharmacies, or there may be some rationalisation when pharmacies can merge. But how deliverable is this? And people are now saying, well, during COVID, we were asked to save the NHS. Well, perhaps the question should have been, the NHS is there to save us. And again, now we're talking about pharmacies protecting primary care and general practice. Well, I wonder whether this is the wrong way round at the moment, and actually whether we're not ending up the situation where the tail is wagging the dog. Your comments would be appreciated.
Before you come back, can I just also add in, years ago, the sort of doctor services overnight, etc., would often have enough antibiotics or whatever to keep you going till the next morning when a pharmacy was open. Do you see that that's wherever somebody goes for that, let's say, emergency care overnight particularly, that is going to have to start happening again? So ED may have to have stuff for, say, a complicated UTI or chest infection or whatever to hand at there, rather than waiting till the next day when somebody has to go to the pharmacy. I think that links in with what John's saying. And Sunday cover, and the geography of that is really important, isn't it? Because we need to remember there are a lot of people that do not drive, and how are we going to manage that?
Yes, I think, I mean, what Councillor Mahoney's highlighted is the very reason why we need to do the PNA sooner rather than later, because, although the current iteration of the PNA didn't identify any gaps across the city, it's very unlikely that a future version would tell the same story for the the reasons we've had this morning. The 7 closures, the 1 consolidation application, and a reduction in hours, and that's just the situation now. We don't know how things are going to change going forwards. In terms of, the other thing I appreciate, obviously, is that the next iteration of the PNA, even if we go early, it's not going to be published until March 2025, which is over 12 months away. That's why it's so important that we engage with the development of the pharmacy strategy, because through that we might be able to change things quicker, outside of the PNA process. So I think that's the key thing I would say is, engage in that and raise challenges and ideas with NHS Devon as they develop that. I don't know if you want to add anything, Dave.
Yeah, John, you're very much right to raise the issue of our services. I think we do have some concerns about that. As a consequence, we've been engaging with the out-of-hours provider and to bring them into the conversations about, what are the risks, how do we actually deal with that? Is that through some kind of pharmacy provision, or is it through what they do themselves in terms of stocks and supplies available? I don't think we've got a definitive answer to that at this point in time, but that issue is recognised as a significant risk, and we are engaged in conversations about what we might do about it. And that's the reason why we're involving those individuals into the discussions about the closures. In terms of actual capacity, the difficulty is to view everything as one and homogeneous system, and it isn't actually. There are big chunks of pharmacy that actually can still and are delivering those services. So there's some real positive examples of services delivery going on in some places within Plymouth. So some, yes, have pressures, but others have great capacity and can deliver these services well. And we are seeing that, and we're actually seeing pharmacies putting huge effort into gearing up for this new service. So I actually think there's a good chance that it's going to be delivered quite well. That doesn't forego the constraints we have and the pressures that we're seeing in the system. And we kind of do need to think about how we do tackle the queues, etc. But that isn't happening every day in every pharmacy location, and actually some areas the access is still positive. So I think it's a mixed picture, but I also do think that the way that our people are engaging with the services that are coming out suggests that we're potentially going to have quite a good response to them. The issue, I guess you're right in highlighting the issue is going to be the capacity, but there has to be actually some kind of funding issue, etc., going on with this to enable us to actually ensure that we have enough people in the place to deliver things correctly. So I think the conversations with government around the next contract, said we had a 5 years flat contract, that is coming to an end. There are new contract discussions going on, and I would hope that that is recognised with the new contract negotiations, that actually it's really, really important to create sustainable growth within the community pharmacy sector so that we can effectively deliver the aspirations of government going forward to be the first point of contact for care.
Thank you. Now, I've got Jemima, Gary, Ruth and Kathy, and I'm going to have to call a line under that then, because we're a little bit over time already, and we have guests coming in to talk about dementia care, so I don't want to particularly keep them waiting too long. So, Jemima.
Thank you, Chair. And through you, I think I would say, I think the going early proposal is an absolute no-brainer. What sanction is there? Who's going to be annoyed with us? How does it work? Where's the issue with going early? The second thing is around the supplementary statements, Rob. How many have you done of those in the past? Have you ever done 7 in a year, or maybe possibly 8 before?
No, I think in the last iteration, so the last PNA, there was maybe 1. So no, we've never seen this level of change.
So I think that's all the more reason to go early, because we really need to underline, and it feels a bit of an emergency to me, to be honest, if you've only kind of done 1 in the past and we're 7, possibly 8. So, and then my second question, and it goes to Michelle's point about Plymouth is experiencing a particular problem. What work are we doing to support pharmacies that might be on the edge of having to do this, especially again looking at the rent lease issue, relocation? I don't know what kind of support there is to support. Where does somebody who's running a pharmacy go to say, look, I'm teetering here? What is there something that can be done to support them to keep going?
I think there's quite a delineation, isn't there, in that it's Boots wanting to restrict the number of pharmacies they've got because they're not financially viable, as against a pharmacy that is finding a problem with rent, etc. Or am I wrong on that?
I think you'll find that all pharmacies are under financial stress at this point in time. So I think the question is that one. And in the presentation I gave, we talked about us coming together to create a group looking at pharmacy resilience. And that will be part of those discussions, working out what we can do and in what circumstance. Though, in terms of the statute, what NHS England can do, it is more limited than it is for a general practice. So it will probably be about, where do we want to actually lay down activity to support the sector. And it isn't, remember, it's not just in the urban sectors we've got a problem. In broader Devon, we've also got significant risks around rural one-off pharmacy locations that would also provide quite significant concerns about what they would mean for population health if they disappeared.
Thank you. Gary.
Thank you, Councillor Aspinall. Some really good presentations and conversations today, and we all know how important pharmacies are inside of communities. I just would echo something from Jemima before I make a couple of points, which is that how do we understand that critical tipping point in terms of pharmacy services in the city, and if we recognise we were approaching that, should we, what would be our critical actions? I think that would be just something that would be really interesting from my point of view. I'm looking at your recommendations and I have lots of thoughts. So I'm thinking item 2, the answer would be yes, I'd be interested in engaging in a bit of the work around the strategy. But I think for me, I wanted to talk a little bit and ask some questions about demand and demand modelling. And I've looked a little at the pharmaceutical needs assessment, which talks about different types of essential services. You've also listed other services that you could start to do. But where's the place which captures that demand over time to see how that profile is changing by the different types of service? Because I think we've heard quite a lot today, for example, supply issues. You talked a bit about perhaps market forces, but I'm just wondering where that demand is going, particularly when we hear from others around the changing ask of pharmacy, and therefore what we see that looking like through this needs assessment period.
I think that's a very fair question. We have a high level understanding of demand, looking at demographics and population, and therefore what we expect to happen as overall impact on health, urgent care, etc. Down to the specific service level, no, we haven't got that level of granularity and understanding. So I guess you could argue that's a gap, but it would be quite a difficult process to actually get to that. But I understand why you're suggesting that's needed.
I guess, and just as an example, we talk about now in terms of the primary care offer for people coming to attend pharmacies and to get advice. And so I'm imagining what we're seeing is a growth in those numbers. And I'm thinking, is it important for a needs assessment to be describing the direction of that growth, recognizing how hard that might be, but it feels like if we can't quite do that, it's going to be hard for us to know that the workforce planning and the strategy is really going to be ticking off those issues. Yeah. So I think for me that was why I'm asking.
I think you are right, and you know, to some extent within the P&A we can, you know, we there is information at our disposal around like items dispensed per head of population and those sorts of things which are included in it. Yeah. I think the thing which to bear in mind is that the term pharmaceutical needs assessment is maybe slightly wrong, because it's not a needs assessment in the traditional way. The P&A is really a control of entry document, so it controls the entry of new providers to the market to some extent, and it you know, as I said, it's used by the NHS to control entry of new providers. So it's not a needs assessment in the traditional form that you might have seen one before. But having said that, we do try and include that information within it in terms of, you know, items, you know, prescriptions dispensed per head of population and those sorts of things. And again, it's probably, you know, one of the reasons why it's fortunate it's updated every 3 years, because things change. You know, the way a pharmacy operated 3, 6, 9 years ago is probably quite different now. So it does need to be updated to reflect what pharmacies do, the way they operate, the change in, I don't know, 15 years ago we probably didn't have many online providers. I had to work out, quickly think then how long ago we did online, but you know, so the pattern of delivery is different now, which is, as you say, why we do need to update it and include new variables, if you like, in the document whenever they become available to us.
And your tipping point question's quite a difficult one, in that different bits of the city you can look at and say, actually, I can see how you can spread that workload, etc. In other parts, you could actually say, actually, I can see that's a real problem, that we've lost too close to each other, whatever. I think part of the question as well is that when we've looked at this, or when the Commission has looked at this, the belief is a lot of these provisions might go online. The reality is we're seeing actually that is not happening to anything like the extent that people believed it to. That people are just moving locations because they want that personal care that's happening at a local level. So it actually is quite difficult to model. And though I have to say, when you look at certain bits, you can see a scenario whereby closures overburden the pharmacies next to them and create, you know, you can see a situation where it might cause a series of collapses. not actually physical closures, but actually them becoming completely overburdened. So yes, there is that risk, but actually evaluating when it is quite difficult because of the number of variables involved. Having said that, you can do some desktop and say, I can see we have a problem in some areas when certain things are put on the table. And I think that's the purpose of why we're saying what we're saying there, like bringing it forward.
Thank you. Ruth?
So to be very brief, I just wanted to very explicitly mention inequalities and how that's connected with access. When we know that some of the pharmacies that are closing are in some of those areas where access might be more difficult to the larger pharmacies, those remaining open, not just for our everyday pharmaceutical needs, but particularly highlighting some of these opportunities where those opportunities are all about identifying early interventions and therefore would be reducing inequalities if we can get them to the right people. And so I think it's a requirement for all of us to consider when we do engage with the pharmaceutical strategy, and obviously I am supportive of both those recommendations, that we are really thinking about and highlighting those issues around inequality.
And I'd just like to mention on that, I think we need to really look at where the closures are occurring, because given the breadth of services that pharmacies can have, if pharmacies aren't available in areas of inequality, then we're actually building the inequality gap, not reducing it. And I think looking at what's happening, there's a real risk that that is happening.
Thank you. Kathy?
Thank you, Chair. My question is, to what extent do you actually discuss with local pharmacists your future plans and get them involved in the consultations?
Yeah, so the community pharmacies have got evening events and actually engagement events. So we've been engaging with what we call the PCN lead. So we have a nominated lead pharmacist for each PCN that engages with the other pharmacies around at PCN level. So we've already had engagement sessions with them, and now we're having online and evening sessions and actually a daytime session as well to engage with the wider pharmacy population. To make sure everyone has an opportunity to input into that strategy development process.
Just to add to that, in terms of the PNA, the Pharmaceutical Needs Assessment, which is a statement of fact at a point in time, and I think one of the things that I mentioned in the presentation is a 60-day consultation as part of that before it's published, and obviously all pharmacy providers are invited to comment on that draft PNA. And any and the responses to the consultation from them and others are then reflected upon in the final document. So there's a 60-day consultation as part of that.
Thank you. And Tony, I would see Healthwatch being one of those essential people. And I know you sit on the pharmaceutical committee, isn't it, or something like that? But I think, to me, Healthwatch is one of those critical people that we need, organisations that we need to get involved, and making sure that people know we're consulting about things. So to me, if you can manage that, that would be really good.
I guess we are, Chair. I mean, there's conversations going on with the NHS Devon strategy at the moment, and how we get sort of patient experience into that.
Stuff.
Mary, could I just ask, part of this process we're talking about you engaging the strategy and the PNAs, etc. Do you want to do that as a Devon and Torbay and Plymouth, or do you want to do it separately? I think that would be really helpful to understand. Sorry.
I think
Does that mean? Sorry.
Yes, I think that's something that we need to decide. But I think there are certain things I want to do as Plymouth, and certain things I want to do as Devon, because that's important. But Rob, you straighten us out on that.
Yeah, my view, I suppose, if I was recommending something to you, then I would suggest that you do the consultation on the Devon pharmacy strategy as a Plymouth thing. Okay, Plymouth Health and Wellbeing Board has a session with the team leading that, and you do it from a Plymouth perspective. Okay, that's what I think is the way to go there. In terms of the production of the PNA, I think we do what we've always done, and we share the joy and the love of doing it with our colleagues in public health teams across Devon, because we lead on parts of it, they lead on parts of it. It's worked really well in the past, and I don't see a reason to change that, because what it means really is that NHS Devon get a document for Plymouth, a document for Devon, a document for Torbay. They're structured in the same way, and it just works well. So I think that the Devon pharmacy strategy, do it as a Plymouth thing. But I think the next iteration of the PNA, do what we've done in the past, and we'll produce a Plymouth specific document, but we'll produce it with a working group that's got representatives from the other public health teams as well.
I see no reason to, digress from that. Now, Sue, you've been very quiet there, and I mean, I'd hate you to think we're ignoring you. So, is there anything you want to input? Do you
No, I
need
think
to introduce yourself to everybody and say who you are?
yeah, I'm Sue Taylor. I'm the Chief Officer of Community Pharmacy Devon and work very closely with David. So I think David's done an admirable job actually of responding to all the questions. I was just going to add in about the engagement with community pharmacies and with any stakeholder. There is also a survey that's been sent out. So when people join in with a sort of think tanks, as they're called, around what needs to go in the strategy, they're also invited to complete an online survey as well, and that's gone out to all the community pharmacists in Devon. But I support everything that David said, and we work very closely together around supporting our pharmacists as well in the network across the whole of Devon.
Thank you, Sue. And I know you've been one of those ears that I've had to sort of go and whisper in several times. So I do value your input into that. So thank you very much indeed. Okay, team, I'm just conscious of the time now. Can I ask you that we have two recommendations: to accept the proposal to go early with the publication of the next PNA and looking at March 2025 as opposed to September 2025. And then secondly, to support and engage with the development of the NHS Devon ICB pharmacy strategy, which in turn will inform a Plymouth PNA. Are you all happy with that? Jemima? Yeah.
Sorry, I got confused with the date. So March 2025, I know we've had the discussion, that seems quite a long time away in terms of what's happening. And I understand sorry, I read it as 2024. I understand around capacity and getting things done and all the rest of it, but actually we might be, we've already got 20% of our pharmacies closing now. We might be so much worse off by the time we get to March 2025. Is there any reassurance you can give me around that? Sorry, before I agree to the recommendations. That's my fault because I misread the year.
Rob?
Yeah, I mean, the trouble, if you like, is that it takes an inordinate amount of time to produce the PNA. It's normally a 12-month lead time to do it when you think of things like, a 2-month consultation as well. That's why I think it's really important that as a board, given the issues that we've got in Plymouth, that the board engages with the Devon pharmacy strategy, because it might be that we can put things in place and make changes to sort out some of this situation that you've been made very well aware of this morning in advance of the publication of the next PNA, because the PNA will literally just say where there are gaps and where there aren't gaps. That's what it does really, whereas the pharmacy strategy, I think, will be the driver of change.
Can I just say then, I think as a Health and Wellbeing Board, we need to put a point 3, which says we are extremely concerned with the number of closures of pharmacies within Plymouth, and that we will monitor this. I don't know quite how to finish that off. Rob, can you help me with that? We need to note it, as I say, we need to say that we are very concerned, but I don't know quite whether we have anything that we can action after that. So David or Rob, can you help with that?
I just wondered if you wanted to involve with that resilience operation that's going on. Yes. That might be the mechanism by which you could influence outcome.
You're happy with that?
Could we add in then at the very latest March 2025 in the recommendation?
We could put that into that's number 2, couldn't we? And then make a number 3, as I say, to note our, not note, but to express our extreme concerns of the reduction in the number of community pharmacies within the Plymouth area and the services that they provide. And we, David, the last bit, if you can put that in.
That will engage with the resilience planning that's going on within Devon ICB.
Can you all support that, folks?
And just that's great. And just the key point to remember is that the pharmacy strategy is due for publication in May 24, so this coming May. So that's the thing we've really got to influence, you know, quickly if we can from a Plymouth perspective.
Okay, so we're happy with that third one to pop in there. Okay, all agreed? Excellent, thank you. Chris, I'm going to bump you now, I'm sorry. If we invite the dementia care people in, because I think they're all on a time schedule sort of thing, so thank you very much. So, David, thank you as usual. Rob, thank you as usual. And we will just have 2 minutes while we get the people in from the dementia care, all right? Sue, a big thank you to you. We appreciate that. And no doubt we will see you again soon, all right? Thank you. 2 minutes while we get a change of seat. Jemima, are you all right? Do you want that stool brought in for your leg? I think it's in the group. We'll go and get that organised. Okay, start again, Louise.
Hello, Louise Barnes, CEO of Elder Tree Befriending Service.
Emma Crowther, Interim Head of Commissioning for Plymouth City Council.
Kate Smith, Chief Executive of Memory Matters.
Hi, Sarah Colson, Lead Nurse for Elderly Care and Dementia at Derriford.
Nicole Quinn, Lead Dementia Advisor, Live Well South West.
Can I thank you, team, for coming along and joining us? And who's going to lead on it? Emma? Thanks.
So thank you for having us join you today. We wanted to just, as you see, become as a bit of a team effort, and we wanted to just walk you through a bit of background about the current position in terms of dementia in Plymouth, some of the sort of going back to basics really in terms of the symptoms and the various services that are available in the city for people. We also wanted to present some of the sort of challenges and issues that we face, as well as how we work together as a partnership to try and do our best for not only those with dementia in the city, but their carers and loved ones as well. So if we go on to the next slide, please. Oh, I got the clicker. Brilliant. Sorry, I'm at the controls here, which is always a bad thing. So we just want to do a really quick summary of prevalence of dementia. You'll all have be aware in the sort of national and local press that dementia is a rising challenge for our society. I'm not going to go through those numbers one by one, but you will see that there are rising numbers of people who are being diagnosed with dementia, presenting with dementia, living with dementia, and also that impacts significantly on those who live with them, support them, and care for them. You'll see that the top number for the which is our local data shows that we're estimating a rise by 2040 to over 5,000 people in the city living with dementia. And the sort of really stark figure on there really is that 1 in 2 of us will be affected by dementia in some way during our lifetime. So a really significant challenge for the city in terms of making sure we have the right services, the right support, and we're looking after people as best we can. Nicole, I think it's you.
Thanks. So the common early symptoms recognised by most people are memory loss, difficulty in concentrating, and finding it hard to carry out familiar daily tasks, and getting confused over the correct change while shopping. That can often be a concern to people. Struggling to follow a conversation or find the right word, being confused about time and place, and mood changes. And some of the possible diagnoses are Alzheimer's, which is the most common form, and probably 60% of dementia diagnoses are Alzheimer's. Then vascular dementia, which follows up around about 30%. And then the other dementias, such as Lewy bodies, frontal temporal dementia, and other rarer forms of dementia, make up another 10% of those diagnoses. There are more than 100 types of dementia, and often the more rarer the dementia, it impacts on younger people having a rarer dementia. Who's pressing my knobs? Oh, thanks. So the process for people coming in to find out how they get this diagnosis, because dementia is not a normal part of ageing, and any symptom changes noted should be discussed with the GP, and that's the first point of contact, because your GP is going to know your medical history, the information about you, and what other things might be going on in your life that could be mimicking some of the symptoms that people might automatically think, oh my goodness, this is dementia. So the GP's role is to highlight any areas that the person may have control over themselves. So it might be, and with the GP's help, so it may be depression, anxiety, those issues which can impact on people's cognitive ability. So going to the GP so he can eliminate all the other possible things that are happening, which will then, once he's done that, and he will then conduct a mini mental, an ACE test, which is about 30 questions. And that will help to clarify for him or her what is actually going on, and do they need to take this further? Sometimes if it's a very obvious dementia, and vascular dementia sometimes falls into that, the ideas of people's other health conditions can have an impact on that. Sometimes the GPs will diagnose that themselves, but the more complex the diagnosis, then they will forward to the Plymouth Dementia Pathway. Next. So when the patients are referred into the memory service, and the nursing teams will be the first team that they will meet, and this is after maybe some complex cases have been taken to a multidisciplinary team meeting to get a discussion around if things aren't quite as straightforward. And after that, then the psychiatric nursing team will meet with the patient, and they will carry out a more in-depth ACE3, which is the Addenbrooke Cognitive I've forgotten what the E stands for.
Examination.
Thank you, examination. So, because I'm not clinical. So they will carry that out, that information, alongside the information that the GP has already sent in, and blood tests and a scan that has been done, will then be forwarded to the consultant psychiatrist, and they will meet with the patient and have the discussion, bring forward all that information, and with their specialist knowledge, they will be able to discuss with the patient what they believe the patient's diagnosis is, and talk about possible medication. It is not a curing medication, it is medication that will maybe slow down, and every medication works differently with every patient, so it is not an option that works for everybody all the time, but it's certainly something to discuss. And they take into consideration people's other health conditions as well. If the consultant also feels that maybe the consultant psychologist needs to be involved as well, there could be some, maybe a couple of meetings that they have with the patient to really clarify and give the patient, to the best of their ability, the medical team's diagnostic conclusion. And they will also, following that appointment, they will, if people have come with or have a diagnosis of mild cognitive impairment, so it's not as yet a diagnosis of dementia, and about 1 in 10 people who have mild cognitive impairment will go on to develop a dementia in a year. So it does raise the risk factor for people. But following on from that diagnosis, the people with MCI are encouraged to come to our memory strategy group. So that's a 5-week program run by our occupational therapy team. And that's a program to support them to find strategies, information and knowledge that can help them to live well with their diagnosis of MCI. If they have a dementia diagnosis, then they come to our team. We're a non-clinical team called the Dementia Advisor Service. And after initial contact with the patients, we also then invite them to come along to a 4-week education program with a supporter. And at that program, over the 4 weeks, we cover my Wellbeing. So it's about how you're living with your dementia, what the diagnosis means, clarifying for people sometimes, or all the time, clarifying for them why the processes are not working as well in the brain as they used to, helping people to understand that this is a disease. It's not something they've done. It helps clarify for the carers a lot of the time that they're not being awkward. This is a disease, and these are physical blockages and breaking down of processes in the brain. And in another week, we talk about staying me. So it's about how to continue living their life well, and what impact that dementia diagnosis has had on the patient and also the carer, but what support is out there for them, including our team and all the teams that, as some of them are here today, that can provide that advice and support to people to continue to live well with their dementia. And week 3 is all about my well-being. So it's about giving people the knowledge and information about being able to be in control of what they can do in their lives to help them live well. And sometimes it's as simple as getting your glasses cleaned so that you can actually take in quality information, because all the information that comes into us is through our senses. So if our hearing aids need a top up with a prescription, if the wax needs clearing, because if we're only taking in poor quality information, this is going to have an impact on the processes in the brain. And sometimes they don't think of these more practical solutions that is in their control and they can make a difference to for themselves. And then in the 4th week, we talk about my future. So they will all tell us straight away, yeah, well, we've got wills in place. So we say, well, that's lovely, but you're dead when that happens. So that's really not much use to you living well with your dementia. So we talk about plans and putting things in place that they are in control of, because often people think that they're going to lose control. But in actual fact, by informing the supporters and carers around them of what works for them, what makes their day go well, it puts the patient back in control of how they're going to live well. Sometimes it's through documents like lasting powers of attorney. Sometimes it's through advanced statements. It's about informing people what's important to you. Because if people come in to support, they will presume, and they will try and do from a very good place. They will try their best, but it might not be what works for the patient. So it's about informing people how communication is so important. And then our team then continue through, and we don't discharge from our team, and we've got 850 on our caseload at the moment. There's 4 dementia advisors, an administrator, and myself. And apart from running the groups every week, and we run those groups 4-week rolling basis and continues apart from May and December. And following on from those, because we don't have the luxury of home visits, during those meetings they've got a chance to meet the person delivering the group, who will also be their allocated dementia advisor. So they will have a named person in our service that they can come to. And they will carry out with them 6 monthly reviews. So every 6 months, whether the people have contacted us because they have a concern, they will, the dementia advisor will be in contact with them. And to make that a review that is worthwhile, not just a, hello, how are you doing? Great, bye-bye. We complete a dementia plan, or the patients and the carers complete a dementia plan. And that is reviewed every 6 months with the patients and their carers to see where the dementia advisor can provide support and advice and refer on to organisations, but also pick up if there are changes. And because we're based in with the clinical team, we can go and speak to the nursing team, the occupational therapy team, the psychology team, and the consultants, and ask questions. And so people don't have to ring round to their GPs. They can come straight to us and chat about what concerns they may have. We'll do a bit of digging, and then we will take it to the clinical team and hopefully provide that ongoing support for those patients. I'll stop now, I think.
Thank you. So the VCSE, I believe, plays a really important role in Plymouth in supporting people living with dementia, you know, helping, enhancing and supporting those statutory services. Obviously, Memory Matters is the prime VCSE organisation to do that, but Eldertree also supports a significant number of people living with dementia, and we work very closely with Memory Matters to provide a really good joined up approach from the VCSE perspective. So just a few bits of data about what we do. So we're currently supporting about 200 people living with dementia and their carers. We receive referrals from anybody really dealing with dementia, Live Well South West, Memory Matters, primary care, social prescribers, but also from people living with dementia or their carers, their familial carers. We provide weekly contact either through a social inclusion group or one-to-one befriending in the people's home, whichever is most appropriate. We generally reserve our one-to-one befriending for people who are housebound because we can see the benefit of getting them out to a group if they are able to get out of their home. So we have over 90 groups across the city, various different activity groups that people living with dementia are welcome to attend any of those. But we also have a specific dementia support programme as well. So for those wanting more specialist support. Most recently, we've also recognised the need to support familial dementia carers. We recognise going out on our referral visits, we assess everybody that comes into us for our referral. And as going out to visits for people living with dementia, we were realising that the carers needed just as much support as the person living with dementia, sometimes even more in some cases. And a lot of carers were telling us that they were feeling, you know, at a breaking point, didn't know what was going on, just needed to talk to someone. So as a result of that, we've set up a specific, we've called it Breathing Space programme in the city. We're in 6 locations across the city. It's going to be 8 from spring 24. And that's providing 2 rooms within the same venue. So the people living with dementia are supported by a project worker and volunteers. And then in the other room, completely separately, the carer has some respite away from that person living with dementia and peer support. Most importantly, they get to speak to people going through the same thing who can actually, you know, relate to what they're going through and offer support. That's been going really, really well. It's been going for 9 months now, and as I say, we're about to roll out another 2 because we see that need is really important. We deliver 48 weeks of provision a year. We think it's really important. A lot of people come to us and say, how long's your course? It's not a course. People stay with us for as long as they want to stay with us. So support's regular, consistent, ongoing. And in between group visits, or if it's a one-to-one, people will stay in touch with people via the phone or additional home visits if necessary and appropriate. We provide signposting and advice to other organisations. As I say, we work very closely with Memory Matters and Live Well, and we'll always escalate sort of any changes or deterioration to Live Well or adult social care or whoever's appropriate. I know we're going to deal with this a bit later on about some sort of challenges and suggestions, but just something to say, you know, we're offering the support. We have got capacity, but we're really finding that a lot of the referrals coming to us are at the later stages of a person's journey with dementia, so more of the moderate to severe end. And actually, as a charity, not non-clinicians, that's almost too far for us. So what we'd really like to see is more referrals from people earlier on in their dementia journey, and maybe a pre-assessment stage as well, where we can support them while they're waiting. But I know we're going to cover a bit more of that later. Thank you.
Hi. So I'm going to give you a whistle-stop tour of Memory Matters, and also I've brought a couple of case studies as well for us just to show the breadth of the kind of work that we do. So Memory Matters is the only VCSE organisation with a sole dementia focus in Plymouth. We've been here for well over a decade now, and have provided all our services based on those with a lived experience. So carers and people with dementia will tell us what they want and we will design a service around it. The mainstay of one of our services that we have in Plymouth is based at Moments Cafe. So upstairs we have an advice and support hub, which we run based on donations. We supported last year over 752 families with support. A majority of those people have either fallen, not sure where to go for help, or are on a waiting list. We run National Institute of Clinical Excellence recommended cognitive stimulation therapy, and we run that twice a week in our centre, which is funded by the lottery currently. We also have a cognitive stimulation therapy plus group, which is a longer day for people with dementia without their carers. And that's a really interesting thing to think about, is that our CST groups are for people with dementia and not their carers, which is normally the first step into a carer having a little bit of time without their loved one. It's normally for those that are mild to moderate stage. But what we find is once they've had those 15 weeks of CST, the carers go, okay, so I need a bit more. So having these 2 hours off is absolute bliss. Thank you very much. What else can I have? We also run 2 memory cafes. We run one on a Monday and one on a Wednesday. We have over 50 people coming along to those groups twice a week. We run 9 dementia-friendly activities in our building, free for people once a week. And I just want to have a little hint. The whole point of Moments was to enable people to really understand where they can get help in a non-clinical environment. So last year we had well over 54,000 people walking through the door. On the back of our menus it says if you need help, this is where you can go. So that all of those subtle ways of making sure that people understand that there is support and help out there, and all our staff are trained downstairs to know exactly what to do when somebody requests that help. We share lots of our learning as well, so we teach cognitive stimulation therapy all over the country. We're currently commissioned by Live Well to support some training in behaviours that challenge for 100 care homes in the city. That's nearly coming to the end. We're supporting Improving Lives on their Caring for Carers Dementia Insight courses for people who are carers. And we have also set up a young onset group, which we run alongside Live Well in our building. I think we had 20 last week. And we run that once a month for people under the age of 66 who have dementia. So there's quite a lot of stuff going on. The reason that our Advice and Support Centre is really beautifully sat is because we sat straddling and understanding all of the services that work along the city that help older people. So it might be that we're referring to Age UK for their respite services or their day centre. It might be that we're referring to the Elder Tree for their breathing space, veterans groups, memory cafes, back to the Dementia Advisor Service, but really understanding actually that Live Well have a lot of work to do. You know, there's a lot of work. They're an exceptionally busy service, and our point in that is where we can support, we will. There's quite a lot of low-level support that we can do. The specialist dementia advisor service, as they are once people are diagnosed, is really important that it sits with Live Well within that medical team, because that's where the crisis is going to happen and that's where people can be assessed quickly. So that's really important that we get a really well-rounded service. So I just wanted to talk through a couple of examples of where the Memory Matters Advice Service has been really helpful. And we see lots and lots of people who are not just the worried well. Some people are in deep crisis when they come to us. A majority of people will go to their GP quite late when they've got memory difficulties. It's been a problem for quite a long time. And normally it's the last thing that people want to do is go to their doctor and have that faced. So when we're thinking about how do we look after people for longer, by the time people are going to their GP, it's quite late. If they're waiting again for a diagnosis, that's longer still. So there's quite a raft of work that we do in the meantime in looking after those people to make sure that they're waiting well. This family that we were working with here had been part of our memory cafe for a little while. And we always knew that the relationship was fairly fractious between the gentleman who had dementia and his wife. They'd moved back to Plymouth after living in Spain for quite some time and didn't really have a support system around them. Things started to get a little bit fractious in their relationship. And at one point what happened is that they would come into the hub regularly, almost every day, because they didn't really know where else to go. And on one occasion, the carer came in, stood in the middle of our hub and screamed, "I'm going to kill him. He's stupid. I want him out of my life." And then she hit him. At this point, some of our staff were obviously on hand to support this, but it just shows you that actually there's a real need to be able to unpick what's okay, what's not okay, and where's the risk in this. Some of the discussions we had with her was if this is happening in public, in front of people, what's happening at home. He was commenting that he was very frightened and that he didn't want to go home, that she was hurting him. Some of the issues that we had when we were referring to the safeguarding team was he didn't have a telephone and she was always with him as the carer. On a couple of occasions, we had to phone the police on the behalf of the person with dementia because nobody could get hold of him. Nobody was able to call him. She wouldn't let him speak to anybody on the phone. And this was a perfect example of carer breakdown. It was absolute carer breakdown. Some of the things that we did, and obviously we referred back to Live Well and made sure the dementia advisors were kept informed at every single stage, because us managing a risk like this, we're just a social enterprise. So there was an element actually involving all of the safeguarding team, making sure that all our documentation was shared with the services so that they all knew what was going on. But ultimately what we had to do was try and navigate the safeguarding team to have some time with this gentleman on their own. One of the other issues, and this is when the police were called on one of the occasions, the carer said, "It's me, I'm really sorry, I've got carer breakdown, I've got my own problems." And the police actually said, "Actually, it's fine, you're going home, it's carer breakdown, they'll be fine." This was all before, and we have to unpick all of this. We have to unpick and say, actually, this might be a safeguarding issue, this might be something that's going on at home. I'm happy to say that, you know, after months and months of working with this family, the gentleman in question is now very happily living in a care home, and the carer is living with her son, and their lives are much, much better. That took a long time for us to unpick, and they would never speak to social services, and they would never speak to the dementia advisor service because they didn't want to get found out that something wasn't going well. You can go to the next one for me. The next family I just wanted to bring up was a really interesting case of a lady who was diagnosed with Alzheimer's disease at 62. And this lady had been struggling independently to try and manage with a husband who didn't really understand dementia and didn't really understand what was going on with her. So he kind of distanced himself from her. He was working full-time. She had to give up her job full-time. So there were some financial worries as well because she was no longer working. The husband didn't really realise what was going on until they went on holiday, and he realised just how impaired his wife had become. She kept attending alone to some of our groups and would tell us that he didn't understand and he didn't know what to do, but that he wouldn't engage with any services. We kept asking him to go back to the Dementia Advisor Service and have a conversation, and he kept refusing. And I think Dementia Advisor Service had a real struggle to try and communicate with this family because he wouldn't engage in it. However, she was coming to us weekly. And we have this thing about actually having eyes on somebody regularly makes such a difference because we get to see where that deterioration is happening. This lady was getting lost regularly while her husband was at work, and police were involved in bringing her back on multiple occasions. She was very anxious and she was very tearful. Again, hopefully, saw her regularly, gave her lots of support, and finally, actually, when her husband was taken into a hospital, who actually had his own health challenges, the son found a letter in the house which had our details on it, and he called us. He didn't really know what was going on with his mum at all because she hadn't told him. I'm happy to say we managed to support quite a variety of support in for him: carers assessments, PIP, family support. We kept seeing her regularly. And she is now also in a residential home. But the whole point about all of these case studies is that trusted relationship is really important. It's really important that people with dementia and their carers find somebody that they can relate to, that they can talk to, and that they can access quickly, because some of these issues come up very quickly, and not dealing with them causes unending distress. Both of these situations had carers who had difficulty in accessing services, but actually with a bit of time to listen and time to unpick and time to investigate, it's a really worthwhile thing to be able to make sure that we continue to see them.
Hello, I'm just going to cover some of the things that we do up at University Hospital Plymouth. Obviously, if you were to walk around, 1 in 4 patients with have dementia that's in an acute trust at any one time. People don't actually come into the hospital with dementia. They come in because they've got something else. So, you know, they might have had a fall, but they have a background of dementia. So it's really important that we're identifying all our patients in the beds. So we're working quite hard to make sure that everyone's got a little dementia flower on their records. And we're also using the Getting to Know leaflet, which is very much like the This Is Me, which is an Alzheimer's document to find out as much information as we can about each individual patient so that we can make their stay as person-centred and as individual as possible. we're working hard with carers to try and change things. So there's open visiting. We signed up to the Johns campaign, which was actually a national campaign many years ago, where there was an incident of a gentleman who was admitted to a hospital. We're not allowed to know where it was, but he basically came in with a leg ulcer and then came out the other end of life, because that particular hospital wouldn't allow his carers in, so they didn't know what he was likes, his dislikes, and he basically deteriorated. So we've signed up to the Johns campaign, so we allow open access to all our carers to come in. Next one, please. We've also done quite a bit. I mean, hospitals are quite a frightening place for the general public to come in, but if you have dementia, it's very frightening, it's very busy. You walk into Derriford and it's like a airport waiting area, isn't it? You know, it's very, very busy. So we're trying to improve the environment, we're trying to improve wayfinding, we're trying to make the hospital as nice as we can for our patients. So we're doing it's an in-house, what we call a dementia-friendly accreditation, so wards and departments can get in touch with myself, and we can make lots of improvements for the each individual department and ward to make it more dementia friendly. And we award them with a plaque, as shown in the picture there, and that goes outside the ward to say that that particular area of department is have gone out of their way and they're doing extra things for people with dementia. We're doing lots and lots of education, so we're linking with University of Plymouth. We run a module on dementia, which started again this week, but we're equally, every single person that works in Derriford has level 1, and anyone that's patient facing has to have level 2 training, and I don't ever have any trouble. People are always keen to come to that training. We're doing, next slide please. We're doing quite a lot to make our patients less anxious, more calm. So luckily we've had some donations, and we've got those cats there. They can be quite frightening for some people, but they don't work for everyone. So we've got cats and dogs. We equally recognise that we've got issues with making sure that all our patients are fed properly, given the right nutrition. So we've done a lot of work on making sure we've got access to finger foods, different plates. You might think, well, why a plate? But actually some patients with dementia can have visual perception issues. So a yellow plate on a yellow tray with sweet corn's not ideal, but you know, equally a white plate doesn't help. So we're doing lots of work. We've got a dementia volunteer scheme going at Derriford now, so we've got volunteers who are just working with our patients with dementia, and they sit with them, gives them some company, meaningful activities, and that's worked really well. We have got challenges, which obviously I'll pick on at the end of the presentation.
Lovely. So hopefully that's given you a bit of a flavour of some of the services and support that are available in the city. The focus genuinely is on how we can support people to live well with dementia. It's not a one-way path into residential care. It's absolutely nuanced support around individuals to make sure we get it right for them and their families. And to do that, our partnership working is really key. So a key part of that is the Plymouth Dementia Action Alliance, which is a really long-standing group that's met since 2011 to bring together, and is chaired by Councillor Aspinall, and brings together all the partners in the city that have an interest in dementia to think together about what are we doing, how can we improve, what do we need to be alert to, what's coming down the road in terms of future needs in terms of dementia, both in terms of what we could do differently and what are challenges we anticipate. You'll have seen around the city the work that's been done by that group around the dementia-friendly city and the signs in the car parks and things like that. So some really tangible examples of that in practice across Plymouth. So we're meeting again in 2 weeks to sort of regroup again and thinking together about our themes and our work plan for the year ahead. And you'll see on the slide some of the things we collectively think we want to focus on over the next year, right the way through someone with dementia's journey. So the sort of the advice and information that's out there. Big focus on timely diagnosis and support, both pre and post diagnosis. Thinking right the way through that journey for carers support, how do we support everybody with dementia, whether they're experiencing that at a younger age, earlier age, more severely, less severely? How do we listen to people with dementia and their families and make sure we build that feedback into our service design, right the way through to the sort of very sad end of things that can happen around end of life. So really working through together the different steps and possibilities and opportunities for people with dementia. Anything you'd add, Kate?
No, I think that's...
And then finally, last slide, our challenges and opportunities. So what we did together was we've identified, excuse me, some common areas. And I know others want to chip in on this, and no doubt you'll have some questions for us as well. We know we want to, a big challenge for us is around the demand for dementia services in the city. How do we manage waiting lists? How do we make sure that people are supported well while they're waiting? How do we get that support in as quickly as possible? And Kate's identified people don't always seek support as early as they could. They are sometimes worried about doing that. How do we encourage them? How do we make sure that they're aware of what's available to them and that know that they will be looked after? How do we reach them really early in that journey so that they're not waiting and deteriorating in their own pathway, and we can get in and wrap around them as best we can? Very important with our carers. How do we really understand, and again the case studies Kate talked through, the sheer day-to-day pressures on people who are caring for someone with dementia? How do we better understand that and respond to that so that people don't get into these terrible situations where they're at risk and putting others at risk as well sometimes? And understanding through some of our citywide programmes around healthy ageing, how do we think as a city about how we respond to dementia and the whole sort of premise of ageing and living well, and improve our approach to those as well. So if others want to chip in, I know we've got lists here.
Always lists. So just going back to the first point about the waiting list and assessment, we know that the dementia advisors have already got a caseload of 850, and there's about 600, I believe. I met with Jo Thompson, the service manager lead for the memory service pathway, just this week. And still some of those are waiting for a significant period of time. I'm happy just to share that we've managed to get a very, very tiny amount of funding to do a waiting well service, which means that anybody that is placed on a waiting list at a certain point will be immediately referred to us so that we can start some work while they're waiting to enable them to wait well. Like I said, it's very short. It's only a 4-month pilot, but we're really mindful that of these 600 people that are waiting and continually more, I think Jo's comment was there was about 50 people a month being referred to the service. So that's going to continue to go up. And of course, not all of those will be diagnosed with dementia, but there's a fair amount of work that we can do just to try and prevent some of that crisis and some of that dipping into, the space where actually they're trying really hard to make sure that they're seeing all of those people under crisis. But I'm sure we can do some preventative work in trying to reduce some of that.
That's great. Okay. So Sarah, I know you wanted to add something.
I just wanted to say that obviously, whilst we are doing lots of, I would say, quite good work at Derriford to improve our care, we have got the big issue of, patients arriving and waiting a long time in ambulances outside. We're one of it's been across the news quite a lot, but we are the second worst trust ambulance waits outside. And equally, I've just completed the national audit of dementia, which is a thing for all the hospitals, and our length of stay is 10 days longer than the national average. We have, and these poor patients are staying in longer than they need to. And the other thing I wanted to bring up is obviously we've got a big issue with placement of our patients, particularly with very high complex needs, into care homes. There's quite a delay there in placing these people, and the odd patient is unfortunately having to be placed out of county. So you can imagine for families having to travel all that way to visit them, but equally it's not ideal being in an acute trust for a bit longer. So I just wanted to mention that.
And as far as the dementia advisor services, we're looking at that 650 coming down the line. So having funding for organisations and teams that we work alongside to give those patients some confidence that they're not forgotten while they're on that waiting list, to which may end up with them receiving a diagnosis, it may not. But the fact that you're on a waiting list and you just feel left, so being able to have experienced teams to give that patient some ability to wait well, as they call it, is really important. And obviously Joe Thompson and our team, when those numbers do go through the diagnostic process and then come down to us, that's something we need to review further down the line. We're collecting the statistics of patients coming in, patients going out. We don't discharge in our team unless people go into full-time care or sadly pass away. So our list doesn't decrease. It started at 299 in 2018 and we're now at 850 with the same team. So we know that there's work there to be done. So.
Can I say a big thank you for this presentation? It's really been enlightening, and certainly it's something that I think we ought to consider going elsewhere. As counsellors, I think we need to be a bit more aware of this. Certainly I was involved in 2011 with setting up the Alliance, and Nicole and I go back way back to then, and we have some very happy and bizarre memories of that time. So this is something that's very close to my heart. And I've got Michelle with her hand up, and then I've seen both Gary and Chris scribbling well. So let's start with Michelle, please.
Yeah, thanks everyone for that presentation. It was great. And as someone who is touched by dementia within their family, I just want to say what we offer in Plymouth is brilliant compared to other areas. I think we do need to concentrate and look again at where the funding is and where the funding needs to be. And I would be keen to be part of that. And, you know, I keep in regular contact with several people linked into this, not all of you, but I would be keen from a CIC point of view to make sure that we maintain those conversations to look at how the whole pathway works. And certainly from a live well pure numbers, but that's not what this is about necessarily, really focusing on how we speed up that diagnosis and changing the way that we do things. But you know, we can't get away from the fact that these people will need long-term support. And the other bit that I wanted to get across, just hearing what Sarah was saying from a UHP point of view, you know, it is something that we're all going to come into contact with. And there's just something about you being the experts and having expertise, but also almost as a city, the city recognising that that's part of our population, and actually how we support and think about dementia in a very different way to perhaps it's something that happens to people who are very old with a grey top knot, and it's just something that it's part of every day and every family and every community. And I don't know what more can be done in that space either.
Thank you. I think
Thanks.
it's, I mean, Ruth no doubt will sort of agree on this. It's something that we're looking at the ageing well agenda. This has got to be an important thing. And I will take exception to the little person in blue at the end of that. That is completely contrary to what we're looking at for ageing well. So I think we've got to find a new whatever you call those things to look for that. So I'm sorry, I'm going to criticise for that, but that's a well-known fact that is the impression of somebody older. So we've got to change that. Yeah. Chris or Gary, did you want to come in at this stage?
Thank you, Chair. So really interesting presentation, and as has been said, really great to see the level of support that's available within Plymouth. There's a couple of areas that I think we probably could look to strengthen in terms of those links across. So things like, as you say, building that awareness for people at an earlier point and the support offers that are already there. how we connect that in with the community builders programme that we've got in order to make sure that we've got the right links there. Also the piece around the hospital discharge process, Sarah, that you raised, and Emma, our commissioning teams are looking at this currently, aren't we, in terms of the support offer that's there. But I think making some of those connections across to the other partners who are supporting individuals and particularly supporting the care homes in that space is going to be really key. And my final point as well was just to make the connection across to the Devon dementia strategy that's under development, and just making sure that we've got the links across and pulling the Plymouth position in as part of that as well, so that voice is being heard strongly.
Kate, did you want to respond to the, particularly I think the strategy?
Both, actually. So my plea is, please can we have a community builder for older people? We don't have one in the city. We've got them for most other sectors, but we don't have an older person's one. If we could have one, that would be great. And help us to link in with some of the Thrive work to enable people to start to think about living healthily. I went along to the Dementia Summit on Tuesday, I believe, which was really useful actually, and also brought lots of the challenges that Devon as a whole are facing in terms of dementia. And I think historically the word was they were waiting for a national dementia strategy before they built theirs. I don't think that's coming, so it's nice to see that Devon are actually doing that, and I'm happy to keep going to those and bringing some of the information back and sharing it.
Thank you, and I think you've got a lot to input into that, not just sitting there quietly. No doubt you aren't sitting there quietly. Gary.
Yeah, clear myself. It's really, really interesting presentation, and nice to see such a rounded group of people coming to talk about this subject from the voluntary sector all the way through up to paid services, because I think it is that whole that helps work to some of these solutions. I'm interested in lots of this, and I'm certainly going to be coming along to the Moments Cafe at some point when I can get it in. But I want to talk a bit about this waiting well and diagnosis and what we do at that point. And I'm thinking about information and advice services as well, because I'm imagining those are some of the things that all of those people who you talked about don't go to their doctor until very late, are probably trying to Google or find out a little bit about. So I'm just interested more in your thoughts around what we've got, whether that's enough or how we kind of develop those things.
We don't think so. We think it's not clear enough. It's not visible enough. There's some, as you've hopefully heard, some fantastic work. We've been talking, Kate, about how through the Action Alliance, how do we pull all the information together? How do we make it visible? How do we make it accessible? How do we make it interesting to people? So that's and you'll have seen on the Alliance slide, advice, information and guidance. It's quite a dry phrase, isn't it? But actually how we bring that to life. Just to say as well, just a bit of a plug for the cafe. They make lovely chocolate brownies, so should you want cake, perfect place to go.
Can I also just add into that as well, is if we don't know, how a carer is supposed to know.
Yes.
And actually they're the ones that should know. So as part of the Alliance, and we are really lucky in this city that actually we all work together. There is plenty of people with dementia to go round in terms of how we look after those. And actually we're better when we do it together, because that gives people choice, and people need choice. But also to enable people, if the Alliance can start to think about actually how does that work, and we can communicate that out to the public, that's going to help them navigate that at a much earlier time too.
And Gary, I think we really need to get Ellie and the comms team involved in this whole issue initially. Nicole, the type of scan that somebody needs, is it a CT, an MRI? What type of scan is it?
It's often a CT scan, and the doctors are putting those in place. Sometimes if it's a more complex diagnosis, then an MRI is involved. But sometimes an MRI might have been done for other health conditions, and that can be reviewed and checked as well.
So in fact, the new mobile system down at Colin Campbell Court is obviously helping, because that's an additional CT scan, isn't it, within the city? So hopefully, and I know GPs can refer directly to that one. So it will be interesting to learn how that's going, and I think we perhaps need to keep a check on how it's being used, and is it being used wisely, to make sure we can get the waiting time for CT scans down. That would be good. Okay, Jemima.
Thank you. You've just asked one of my questions, Mary. Early come, you know, in my portfolio of children's early, everything comes back to getting things diagnosed early. And I guess I want to understand what, so the comms thing is one thing. We really need to encourage people. And I guess you're kind of scared when you initially think this might be you and you put it off, and people tend to do that. So I think being more, sharing even more publicly what support is on offer is really, really important, because hopefully that will encourage people to do that. I went on a visit to a number of care homes in my ward of Stoke, and one of them, Parkwood particularly, had this, just talking about how the city works, they have got corridors, these really incredible corridors, which are all based on, you know, jogging memories, and they're just incredible. And I just thought the level of trouble that they were going to make those places comfortable for people with dementia was extraordinary. And hearing you all talk together and you work together, I think, you know, we have a really brilliant foundations to light away. I don't mean that, it's much more than that. But the early thing is obviously the nub of it. And so that, you know, whatever journey people have to go on, they can get support for as long as possible. So I would absolutely support anything that we can do comms-wise about a reassurance, rather than kind of symptoms necessarily, but kind of, if you think this might be you, don't be scared, because actually we have this in place or this in place, or you might, you know. So I think it's something about making it clear that we've got a lot of support, but again, taking on what you're saying in terms of numbers, what we can do to make that easier there as well. I think your presentation was brilliant, and I feel incredibly proud of what the city is doing. And I would also back Kate's suggestion around community builders, because again, they could be very good at disseminating information, which hopefully could make things a little less threatening and scary for people.
Thank you. Yes, we need to definitely look at that. I've got, Nicole, do you want to come back about a particular thing, and then I'll go to...
Yeah, just saying that we used to have a lot of education done in schools around dementia, and quite often it's grandchildren and children starting to have that conversation with parents and grandparents that can help reduce some of those fears and concerns, and building that awareness and understanding. And you know, it's something I don't think is in place at the moment, but a trainer, an educator for schools, council properties, buildings, all that sort of thing, shops, retail. Just because we have dementia doesn't stop us being a shopper, and that awareness, you know, it's almost like a bit of a mystery shopper sort of thing. Back in the day, somebody got a sticker. That shop might have changed hands, different staff. So it's something that needs to be ongoing. And I think that's building that awareness, bringing it into a regular, everyday conversation will help people to seek that support and advice at an earlier stage.
We definitely had dementia-friendly certificates or whatever, didn't we, when we first launched? So I think that is something to look at. And again, I think, Ruth, that's coming back to looking at the ageing well thing also, I think, so that would be good. Right, Tony.
Thank you, Chair. Absolutely brilliant presentation as far as I'm concerned, and it's great to see how well linked up everybody is in what you're delivering and what you're dealing with. I've got an offer for you. So the offer is, we are just finalising a report in some work we've done with unpaid carers across the particularly looking at carer isolation and well-being. And within that, one of the questions was about the condition of the person that you were caring for. So the engagement was a mixture of survey and some guided conversations at the end of it. I can get the team to have a look and see if there's anything dementia specific But even if not, I would have thought the experiences of those carers would be useful just to understand that. And to give an idea, we spoke to, I think it was survey-wise, 224 across Devon, of which the majority were Plymouth, by the way. And we've done 17 guided conversations, of which I think 8 were Plymouth based.
What's the timing of that? Just in thinking about our alliance meetings, we could build that in as well.
Yeah, we're aiming to get it finalised by the end of the month. I think we're not going to be there, if I'm honest, because of other competing factions. But certainly, you know, in the next month, we would want that to be published.
So can I leave that with Kate and Emma to action that, please? That sounds a good idea. And Kate is dying to say something.
I'm sorry. I just wanted to say that I straddle borders, so I work in Cornwall as well. And something that Cornwall did that was really helpful was they engaged Healthwatch to ask, send questionnaires out to people with dementia and their carers to ask about their experience. And what they've done is they've used that information. It's called the Hear Our Voice report. But what they've done is they've used that to inform their strategy going forward, so that it's from the person with lived experience. So it kind of goes along listening. And listening and informing and shaping services around actually what people are needing. Just want to shut that in.
Thank you. You better get cooking with the brownies. That's all I can say after today. Anybody else want to come forward with anything? No? Okay. Can I just say thank you very, very much. And I'm obviously looking forward to 2 weeks for the next dementia-friendly thing. And I think we need to get pushing on certain things. I think Dementia Friendly City has sort of tailed off slightly. I'm not saying the work wasn't going on behind the scenes, but it's lost its prevalence and its importance within the city. And I think we need to make sure that that's resurrected, because the work that is going on is absolutely amazing. It really is. I will treasure my visit down to you, Louise, down there. I know Sue, Eddie and I are coming down again. So that'll be really great. But I think I would say to anybody, if you want to see what's going on and what everybody down at Live Well is doing, you know, Louise will welcome you with, not Live Well, sorry, Elder Tree are doing, Louise will welcome you with open arms and
absolutely,
be very happy.
anytime.
Yeah. Thank you. There's quite a few bits and pieces, hasn't there, that's come out of this. And although we've just being asked to note the presentation, there are a few recommendations, Elliot, and I don't know if you've managed to catch them, but one of those is to make sure that I think that we need to be making sure that this links in with the Ageing Well agenda within Plymouth. And I think Ruth and I would be very happy to take that on board. And I think certainly there has to be a request about exploring again about community builders and their understanding of this, and whether we can get a specific community builder post for dementia would be really, really great. Or whether there we are, we have something. So I think, Chris, that's something that we need to work out, because it's a joint thing, isn't it, between us and the council and you at the moment. So anything else that anybody wants? I mean, the comms thing, we need to make sure that there is a good communication strategy about dementia. But anything else that anybody wants specifically to pull out? Jemima?
It's not a recommendation, but it's just where the 8 places are, or when there will be 8 that you were talking about, Louise, because I think that might be quite good to share with councillors if they've got them in their wards or nearby.
You're going to test me now.
Don't worry.
I'm not asking you to tell me specifically now, but I think it might be quite good to share that.
And then my final recommendation would be that we need to be making sure that councillors, as community work people, need to know more about dementia and activities that could take place. And I think, Kate and Emma, that's probably something that I would, if we work on over the next couple of weeks and bring that to dementia friendly meeting, and that needs to really be something that, as I say, I think councillors need to know, and they can certainly be pointing people in the right direction. And again, that comes back to also our website as well, Plymouth City website, making sure we've got the right information. So there's some homework for you, of quite a few people here, but I think that's what this sort of thing is about on the Health and Wellbeing Board. It is that well-being of our city, and that's what, to me, is what's important. And Gary, I suppose the other thing came out about that you were saying about 10 days extra stay in hospital, and whilst ambulance waiting times are well, that's the most difficult thing I think for us to solve. But I think making sure that we have care homes or whatever in place. So I think that's perhaps a dialogue that we need to have about that as well. All right, thank you very much indeed. Thank you, team. Much appreciated, and thank you for your time today. All right. No doubt, Michelle, they will be in touch with you, and a big thank you to you for your input there. And I think we need to follow up on that as well, your suggestions. Okay, Chris, I do apologise for sort of doing this, but we need an update from NHS Devon, please.
Sure, thank you, Chair. And recognising the time, I've obviously provided some detail in terms of some highlights in a report that's come out in the pack. I think, you know, so this is the first of these updates that we've delivered into the Health and Wellbeing Board, and particularly for since I've been a member. Keen to get some feedback too, if it's a useful level of information to bring into this group. Happy to do so on a continuing basis if it's useful. You'll see I've structured it in terms of some of the highlights of things that have happened at Devon system level, but also with a particular Plymouth focus too. I think recognising the particular point of time that we're in, the depths of winter, and what we knew would be a very challenging winter for the NHS this year. Absolutely, that underpinned our winter planning process that took place, which this group heard about earlier in the year as we were taking that forwards. I think it's recognised that the hospital in Plymouth, and actually hospitals across Devon, soon after Christmas, the early part of January, found themselves under extreme pressure that coincided with the industrial action that was taking place. And that did result in us entering a period of critical incident. What that means is it enables us to bring a total focus around the hospital systems, bring partners together in different ways, and look at how we prioritise services for those with the most urgent and emergency needs. And that process enabled us to step down from that status, and we did see some improvements. I think Derriford has seen a spike in demand since last weekend, and had itself re-enter critical incident just from a Plymouth perspective. We've continued to support and work with the hospital system in how we respond to that. There's been some really good progress made around the hospital discharge position, so actually those number of individuals who are waiting in the hospital to leave, through the joint work that we've done in our initial winter planning, some of the additional resources that we've put in place jointly between the ICB, Live Well's involvement in that, and Plymouth City Council has seen a big difference, and we're certainly in a better place from a discharge perspective than we were last winter. But there's always more we need to do, and actually the pressure in terms of the numbers of people who are currently within the hospital and the high level of acuity that they've got is something that's continuing to challenge at the minute. There is some positives though as well in terms of some of the other programmes of work that have been put in place in order to support the health system and the local population. So there's some reference in there to the virtual ward scheme, for example. So that's some new additional capacity to support up to 50 people at any one time in their own home with enhanced wraparound support. We've also got the acute respiratory infection service that's been mobilised and working alongside primary care networks, a number of primary care networks within the city, to bring some additional capacity in to support what we know is an area of particular pressure and need. So that's a really, really quick snapshot in terms of the detail that's there, but happy to take any questions or follow up around that.
Thank you very much. And obviously we are very much aware that Derriford in particular is pretty stressed at the moment, and I think we know that everybody's trying to work hard to sort that out, but it is a very difficult and traumatic time for anybody that's having to go to hospital, really, isn't it, at the moment? John, I know you've got something to raise.
Thank you, Mary, and I'll be brief in view of the time of the meeting, but I thought I'd raise a couple of issues, and Tony's here, probably be interested to hear what he might think and whether he has any other input. General practice across the city, very varied access, how you do it, how easy it is, how accessible it is to patients. I mean, we all hear this. I think Plymouth has a bigger problem or bigger divide than perhaps the rest of Devon. I think fortunately some of the practices on the west of the city that offer services to the more deprived sections of our population are actually working better than some of the others. But I mean, I went to the GP on Tuesday, the whatever it was, day after the bank holiday in January. Expected it to be heaving for a blood test. I didn't really think I needed, but I went, partly out of interest. I was the only patient there at 20 to 11 in the morning. There are 56 seats in 2 waiting rooms. A couple of people had just left. I was the only patient there. When I left 20 minutes later, there were 2 or 3 more. But, you know, what is going on? Because I would have thought that would have been rammed. Full waiting room, well, not full, it was ridiculous. In the old days, people are timed better, but people waiting to be, you know, seen at the desk and asking questions and whatever. I mean, I just could not believe it. I hear this from other people, and it isn't just my experience, but that was, you know, the mid-morning, the day after the bank holiday New Year weekend. So are patients actually being seen? Where are the paramedics who are seeing patients, the nurse practitioners, the farm? You know, it's not just the GPs. So where are the people, the staff, and where are the patients? At the end of the week, my mother didn't get a visit on the Friday, which I think she should have had. Saturday, 111 at 8:30 in the morning. She got the visit 28 hours later. Numerous calls to 111 across the country, wherever the call gets picked up. There's no central system. They don't know where someone is on the list unless you happen to get one of the 111 providers that is on the same system. So the whole Saturday I had no idea. Triage call at 12 hours later on Saturday evening, yes, from a paramedic, you do need a visit. Happened at 12:30 on the Sunday morning, by which time I did know it was going to happen. You know, it's not about my mother, she survived it, but what is happening in general practice? There is no consistency. Do we really know what's happening? Are we being told the right information by the GP representatives who talk to Devon NHS? I wonder. Today on the radio, all these, 36 million appointments a month apparently that meant to be happening. Well, are they all being double counted because the population is being seen at an enormous rate if they are true? Some of them are the same people being seen multiple times. What is happening? What's happening with the 111 service, which can't be just my mother who had a problem that weekend. There were no GPs working for it. The GP came from Oakhampton on the Sunday morning. I think she was a GP. So want to raise that, whether Tony's receiving any worrying messages recently, but something is not right, and it all starts with general practice. If general practice does not function, it puts the pressure on 111, 999, A&E, the minor injuries unit, and in the end, it's Derriford that gets the brunt of it and goes pop.
Before I bring Chris in, Tony, is anything you wanted to add? Because obviously John's mentioned.
I guess from a 111 point of view, we've had a look back over the last calendar year on feedback there. We've only had 21 pieces of feedback across the whole of Devon, but I think there's a consistency in what that feedback is saying, and that is when a callback is being arranged, and the length of time people are waiting for that callback. A couple of them said they've never been called back. So whether that was a missed call or whatever, and it's difficult for anybody to go in and look at that without patient details and the timings of it. But it does appear that you've gone through the triage at 111, and it's agreed that you need a clinician callback, that those callbacks are very very difficult to predict of when you're going to get that. So if the operator said you should get a call back within an hour and you're still there 12, 24 hours later with no call back, it does leave you wondering as a patient or as the patient's carer, are you going to get any support? And I guess you start automatically thinking, it's a weekend, the only place I'm going to get support from is the ED. So I think there's factors there. In terms of GP access in Plymouth, I would agree with John. It is a bit variable between different surgeries and that, but generally, From what we're hearing, if you need to be seen urgently, you do get seen within 24 hours. Now, that may be a phone call, that may be a video consultation, or that may be an appointment face to face. So I think it's more routine ones where there's 3 to 4 week wait for that to be booked in because of the availability, I guess, of slots. And again, whether that's done by a phone call or a video conference or face to face is there as well.
That's only, I mean, I think it's a question of some non-urgent things aren't being seen because some practices will only see things on the day as if it's an emergency, and for a lot of people it isn't. And I actually wonder whether there's a lot of stuff, death rates are rising for all sorts of reasons, COVID related and other factors, but you know, are there patients out there who are just not getting seen? And I think there are, with potentially things that could be serious, even though they're not urgent at that moment.
Interesting perception. And I think, Chris, if you could come in, I mean, it's two things there, isn't it? It's GP services and 111. And you've got some sort of say in both of that area, basically, with NHS Devon, haven't you?
Thank you. Yeah, so John, it's a really good point that you raise, and in terms of the personal experience there, I guess, so picking up the two areas separately, so the general practice piece, so we've been having some conversations already through the local care partnership around actually what's the metrics that we're looking at in order to understand the delivery of primary care services within the city. As Tony described, if you look just at pure access rates, you know, that tells one story, but actually what are the other things that we need to look at? And I think that's going to be really key in terms of understanding that, John. I'm happy to think about how we link in and get some input into that as that goes forwards in terms of developing that work locally. In relation to the 111 ask, so similarly, very happy to go away and have some conversations with the patient safety and quality team within the ICB, who will be looking at the data that's available to understand actually what's currently happening. Is this service operating as we would want, and is there further things that we can be doing, recognising, as you say, the opportunity lost in effect if that service isn't operating in the way that it should do. So agree that's absolute priority that we need to look at. So that's something I can take back and come back to you on.
Thank you. And if you'd come back to us, particularly about the 111, I think that would be very, very useful. I've got Gary, then I've got Jemima.
I just wanted to firstly say thanks to Chris for the report, which talks about quite a lot about some of the things that have been going on. And I guess I just wanted to link it then to some of that other conversation. In terms of looking forward, there are already conversations around, aren't there, around some of the work that might need to happen through primary care, through GP, and it might be helpful to get that bit of look forward, and then for this group to think about some of the things it wants to see and talk about moving forward. I would say there's a lot of focus through systems around trying to help discharge flow, clearly because of the acute clinical needs around that. We've seen some quite good moves there. The eyes are beginning to turn, aren't they, around admission avoidance schemes. I see virtual wards on here, but also what's going on out in primary care, just to make that link in GP. So I just wonder whether that might be something that we can think about for future agendas as well.
We'll certainly note that. Thank you. Jemima.
It's a quick thing in terms of asking for feedback on the report. The first thing I always look for in anything of this nature is around dentistry. There's no mention of dentistry in it, and I just wondered whether I realise you're reporting on pressing issues, but most other areas are covered in one way or another. So I didn't know if a paragraph about dentistry in each report would be helpful.
Chris, can we ask you to add to that?
Yeah, that's a good point. I'll make sure that's in next time.
Thank you. Before I call Michelle in, I'm going to just basically say a big thank you to Michelle and the team that have been running Mayflower Medical this last year or so. Certainly the service, I mean, I've got to say I declare an interest as a patient, but the service certainly has improved tremendously. Whilst access to a GP is like the same anywhere else. I've got to say that the nurses and the paramedics, certainly down at the surgery that I go to, have been absolutely first rate. Their service continued all the way through COVID and through all the restrictions, and certainly it's been brilliant. So from my perspective, Michelle, please, I mean, they always know that I value them, but, you know, certainly from me as chair of Health and Wellbeing Board, I would certainly like to say a big well done and thank you to all of that. And it will be an interesting time with the change of service. So I'm really quite disappointed that you had to not take part in the sort of going forward with the contract, but certainly understand completely after reading the report, your annual report. So, as I say, a big thank you, Michelle. Over to you.
Thank you. And I have to say, it's I'm really sad, and it's something that the board didn't take lightly and we agonised over. So it's something, you know, we're very proud of what's happened and what the team have achieved. You sort of thrown me a bit there, Mary. I just wanted to thank Chris as well with that report, because it's informative, but I think it doesn't quite get the essence of how well and joined up all the systems have been. And I think that's the difference this year. So where I agree, GP's variable, and, you know, gaps in GP practices are all over the place. But actually the way that health, acute health, community health, mental health, social care have all worked together, and to actually look at developing new services and looking at where we can have the biggest effect. And certainly that focus on prevention and the virtual wards, and the fact that that's an acute and a community offer, and just working seamlessly together. But I have to say, Chris, you are one of the people who really speak up for Plymouth and the Western system in the ICB, and I just want to thank you in front of all these people to embarrass you even more than Mary has me. So thank you.
Thank you. And you know, Chris, yes, this is great to have this liaison, and certainly we appreciate that the oversight framework is not the easiest thing to be working in, and that the financial problems and concerns are there and will be ongoing. And I certainly know that Sarah Wollaston is very adamant that we've got to, and Bill Shields are very adamant that we've got to get back to a better situation. But it also needs, with looking at the fact that we need to be providing a brilliant service, and I know you're trying your best there. Okay, any other questions? No? Lovely. Thank you, Chris. And we look forward to the next report with dentistry added, she says. Right, we come now to tracking decisions. An hour late, but never mind.
We got there. Thank you, Chair. So the board will see there's 3 tracking decisions in front of you now marked completed, and 3 still in progress. One of the ones, I'll draw your attention to each one. The first one's been added to the work programme, so I'm marked as complete. The second one is going to take more time to actually fully investigate the issues. Several of the bits of information, including the carers request that we requested last time, are quite in depth. And so while you'll see on, what page is that? Page 54, there's an extensive response there from Emma Crowther on behalf of the carers item. But there is still more work to be done to analyse the statistics. The last thing I'll draw your attention to is the CPR training for counsellors, which is the last recommendation on your sheet. And just to note that the 30th of January is your last opportunity. Thank you, Chair.
Thank you. Anybody want to raise anything about or ask any questions? No? Hopefully we can get more interest with the CPR training for counsellors, because that seemed to be, and that was something that was raised in council, wasn't it? So I think probably next Monday I need to remind councillors, if they haven't, they're running out of time to do it, so we'll sort that. Okay, item 12, the work programme. Oops, sorry.
Thank you, So unusually, I've managed to quite pre-fill this one. They are all obviously subject to review and approval here. But these are all based on what we've discussed over the past couple of meetings and lined up as due to come back. So an update on the dental task force. Obviously, we had one at the last meeting, and at the next one, it's going to have been about 4 months. The next meeting of the dental task force would have taken place, so therefore it makes sense to sort of bring that back and have a look. Thrive Plymouth next 10 years. Ruth, I don't know if that one will be ready for March's meeting. I've got it down as available.
Yeah, I think so.
Perfect, thank you. And then Plymouth Suicide Prevention, Kamal Patel, and the last one would be an update on the vaping working group, if we've held it in time by that meeting. Thank you, Chair.
Yes, that vaping one will depend on what government come out with. So, yeah. John?
Thank you, Elliot. What about the things on the outstanding schedule? There's quite a lot there. Couldn't put them all in one meeting, but what about the NHS long-term plan and recovery plan? Doesn't that link all sorts of things together? What are we doing with that?
Chris, that's part of your remit there, isn't it?
Yeah. So yes, we can do, and I think we should do, and actually Gary's made the point around the local care partnership priorities, actually looking at how we bring those two things together, which will obviously be shaped by components of that too. So we could look at bringing those two items at the same time.
When do we think time-wise?
Possibly we might be able to give some update in March, might be better for the next one. I'm just thinking in terms of some of the other conversations, the operating plan discussions that are underway at the minute, and just making sure we've got that navigated perhaps before bringing it back in.
And the safeguarding, that probably would be useful once the annual report for 23 is ready, isn't it? Whether we bring something from the safeguarding board later, June-ish this year.
I think, yeah, I mean, it'd be good to bring it. We can just check when they think they're going to have it available and just put it into the following Health and Wellbeing Board. So we'll link across with the partnership for that.
And Ruth, the annual update from the Plymouth Health Determinants Research Collaborative, that will fall into a pattern as well, won't it? Probably the summer for that as well.
Yes, yeah, that'd be great. That's fine. Whenever you want, really.
Lovely. Thanks very much indeed. Okay, and I think if anybody's got any more topics that they want to bring, Tony, it would be quite useful to find if you could just give us heads up when you're going to be doing surveys or talks and stuff, from the comms point of view, so that we can make sure that we let people know, and B, obviously for what comes to us, because I know you're very active with your reports, and it would be interesting to have sight of them. So we'll keep in touch about that. Thank you. Okay, I think that's it, folks. Thank you very much indeed for your input. It's been really, really useful, and I think we've got a lot of information and a lot of work done as a Health and Wellbeing Board, and we just need to pull some of those strings together. So thank you all very much for your time, much appreciated. Okay, farewell team online. We will see you soon, no doubt. And thank you from here. All right, take care, folks. Bye.